There it is. Yes. Okay. Well, good morning. I'm Tony Laurie, Chair of the Prescription Drug Affordability Board, calling to order the May 12th, 2026 meeting of the PDAB. I note that we do have a quorum with 6 people present and expect the 7th online. If we don't get the 7th online, you could actually vote without taking the roll. That's not to say that we don't want the 7th to join, but that would be a treat. That would be a treat for us.
Shave off 30 seconds.
But we do have 6 members present. I do not believe we have either of our non-voting members, but they are both in the legislature and pretty busy right now. We are, I believe. For members of the public, please note that public comments will be submit written comments anytime, and those comments are shared with the entirety of the board, and we do read them and pay attention. An agenda was published on our website with 7 items, and we will proceed with that agenda. The first order of business would be to approve the meeting agenda. Did anyone have any additions, corrections, anything? Okay, I would approve that agenda by unanimous consent. And then we have the meetings from the April 14th, 2026 meeting. I read them. I didn't have any additions, corrections. Anyone with any additions, corrections on the minutes? Okay, we will approve the minutes as presented by unanimous consent.
I have to abstain, I think, for me, because I wasn't present for the last meeting. So.
But it's unanimous consent. I think you're not objecting, and you can.
I can still.
Yeah, you can.
Yeah, that was.
No. So that brings us right to the PBM presentations. We have 3 of them here, and let me just sort of go over the timeline I'm hoping to have this week, this month. We're hoping to be able to do the 3 PBM presentations in about a 45-minute block, maybe 15 minutes each, give or take, because the data project is our main order of business this month, and we've tried to set aside 90 minutes because it's time. We're just about wrapping up the contract with Joel at the university, and it's time to start actually digging in and working with the data, and we want to make sure that we reserve enough time with that. That leaves 15 minutes for the executive director's report and enough time for public comments. So just in terms of trying to set the stage for everyone, we will go ahead and call on the first of our PDAB presentations, which my understanding is Express Scripts with Andy Bain. Andy, welcome.
Thank you. Happy to be here, and we'll try to be respectful to the time. I know that you guys want to keep us within that range, and so I can be as efficient as possible so my colleagues will have ample time also. And just a question, did you want this to be interactive, or how are you kind of looking to design?
It's most of the presenters say happy to take questions as we go, and oftentimes we get questions as we go. So if that's okay with you, that seems to work well.
Yeah. I've got Tracy Hester with me, so she can answer all questions. So
okay.
Good morning. Thank you very much for having us. Andy Bain, I'm from Express Scripts. I was just catching up with Vern before this. I've been at Express Scripts for 25 years now. My team is based in Bloomington, Minnesota. I'm a graduate of the University of Minnesota College of Pharmacy and served a term on the Board of Pharmacy in the state of Minnesota. We in the Bloomington area have it's called an admin building with a variety of different functions, and that's really the pinnacle hub for our company. So for all the sense that a variety of positions and pharmacies that are based right off of 494, right around the corner. So that's really what we're all about. And they've got me giving kind of a business presentation to some degree. So I mean, I will say in like full disclosure, I'm comfortable with talking points. I know the direction, and we'll do my best to do our best and answer questions. And
Say, Tony, it's really hard to hear online. I apologize for interrupting.
This is Greg. We have our 7th member.
okay.
Anything we can do with the microphone?
Yeah, I'm gonna turn on the cancellation, see if that improves things.
And thanks, Greg. Will, give us some feedback when we get things.
Dr. Garcia mentioned there's a weird background noise. I don't know what that is.
Maybe the cancellation will help with that.
Yeah, I think the cancellation that you just turned on is helping. It's a lot more clear.
Yep, it sounds better. Thank you.
And the volume is sufficient?
It is, thanks.
Great, okay. Thanks for everyone working on IT. Back to you, Andy.
Team effort. Thank you. Yeah, just the tee up. Obviously, we know within the prescription market space, affordability is a problem. There's a wide range of problems that we hear from different stakeholders, and we're hoping by the end of our presentation, we can provide direction in terms of what we're trying to do to correct and improve those issues, and hopefully set a course of action for not only ourselves, but perhaps for the broader industry in the future. That will be something that will be more amenable to affordability from a patient perspective, affordability from a client customer perspective, and certainly, hopefully, better from a patient outcome perspective also. We've been a leader within the PBM marketplace now for several decades, and we have a history of trying to address these problems head on and trying to improve the market space for everybody. We can probably move to the next slide. In terms of some of the examples, you can see this is just a small snapshot. Like I said, I've been with the company for 25 years, and it feels like every year there's some new initiative that we're taking on, that everybody says, there's no way we can do that, and then you align, stakeholders, and you're trying to do the right thing, and, you see success. And so these are a couple examples. Hopefully they speak for themselves. I know some of them have been very prominent topics in Minnesota in terms of capping insulin pricing, ensuring that there's transparency to pass through pricing for clients and customers. You can kind of see the succession year after year. And I mean, it's almost like every year, but I can go back, there's 15 or 20 more of these that we've had year over year. But by the numbers, these are interesting numbers. I'll just cite them. At this point in time, more than 95% of rebates are passed through to clients today. The average 30-day prescription for a patient is around $15 on average out of pocket. That's through employer-sponsored coverage. We have seen a growth in contract with independent pharmacy within our network since 2019, which is good. It's healthy for the marketplace. We want patients in rural locations. We want independents to thrive. So that's been a point of emphasis for us. And about 35% of our network is independent pharmacies. I think we might cite this somewhere else, but I'm sure you guys are very into this from a drug pricing perspective. But for most of our clients and customers, they're seeing anywhere from 90 to 95% of their prescription volume in generic medicines. And so what we're really talking about when we talk about affordability, not exclusively, because there can be some higher priced generic products occasionally, also that rogue product or, that hits the marketplace, but it's that 5 to 10% of the marketplace that's branded products that just have exorbitant price points on them. And that's through a lot of orphan approvals, it's through a lot of oncology products that have been approved. We've seen a variety of some controversial accelerated approvals through FDA where you're even wondering, we're not going to know for 3 or 4 or 5 years, and it's incredibly expensive. So a lot of dynamics in the marketplace from an affordability perspective. It all doesn't hit every patient. Those patients that it hits, it's disproportionate and heavy and hard with incredibly high price points. I think this is an approximation, but when my team has looked at the average list price of a newly approved product, we've seen somewhere in the neighborhood of maybe 60 to 70 unique molecular entities with biologic license applications approved over, let's say, the last 3 to 4 years. The average price point on those continues to go up year after year. And, Steve, you probably know this better than anybody in here, but I think we're talking several hundreds of thousands of dollars per year on average for any of those approvals. So it puts strain on the marketplace for sure. I wouldn't be even accelerate because I know we need to go. Well, maybe you can go back. You can go back to the last slide. That's okay. I'll hit that real briefly. So, I kind of preface this whole thing by saying we're going to talk about something different today. And what we're going to talk about is a fundamental change in how we're designing the pharmacy benefit for our clients and customers, with really these three goals in mind: lowering drug costs with upfront discounts for patients. So from a rebate perspective, the patient obtains the benefit at the point of service. So if there's a rebate associated with the medication, it's the patient that benefits 100%. That all gets passed through right to the member, takes everything else out of the equation. In terms of clients and customers, transparency into the costs and the compensation, and we would just be compensated a simple administration fee that has nothing to do with the price of the medicine. There's been another complaint, which is you want higher priced drugs because when they're higher priced, you make more. In this model, it doesn't matter what the price of the medicine is, it's the same administration fee that you maintain. And then from a business perspective, there's not this razzle-dazzle in terms of, okay, a rebate flow and a check after the fact, reconciliation. It's just very clear with clear auditable tracking.
This is a business model that you have upcoming or that you're developing right now?
Yeah, we're building. We're building suspense.
Okay.
Just hold on.
Okay, this is all really interesting, but I am thinking about the folks that might be watching this and are listening, and people like, what's a PBM, right? So at some point, it would be good to sort of have an understanding of like where we are today, like what PBMs are doing and where you think that value add is as well. Love to see where you're going, but.
Well, that's why I've got colleagues.
Yeah, okay, great. That's fantastic.
I think I'm kind of starting out with the new thing,
Great.
and then maybe my colleagues will nail the.
Good, because we want to do some education.
The stuff you really want. Okay.
No, but this is interesting.
Yeah.
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 So in the kind of the third stakeholder here is pharmacies. And obviously from a pharmacy perspective, we certainly hear about independents and rural pharmacies struggling. And to the extent that we can be partners with them so that they are reimbursed on what they're paying for medicines from an acquisition cost perspective, as well as obtaining reasonable fees over the top of that to sustain their business model. So I think those are the three stakeholders. And then we can move into the next slide, which is a little deeper dive into those stakeholders. So this is kind of maybe where you were going a little bit is what's going on today? And then what's this new model that you're talking about? What does this all mean? And so I don't want to drain the slide just for the sake of time, but you can see, and I tried to touch on some of the problems. Today, from a patient perspective, there's a rebate or a discount that we negotiate that goes to our client or customer. The patient doesn't see it. And that becomes particularly problematic during the deductible phase of the year. Because in those first couple of months, their medicine, they're paying full fare. As we talked about it, if you suddenly are on one of those high-priced medicines, you show up in a pharmacy and your bill is $10,000. And like, who's got $10,000 to just pay right at the point of service, right? And so with the new model in terms of passing rebate on, the member obtains that discount right at the point of service. And it goes one step in the sense that it's not just the rebate that will be passed, but we do get into it in a future slide. With our systems, we're trying to change our systems so the member will pay the absolute lowest price that's available. So if it's a net rebate, if it's a cash pay, if it's a variety of other, and I'll kind of get into them. There are other ways that the prices can come through. The member will always get the lowest out-of-pocket costs at the point of sale. So that from a member perspective.
Can I speak a question? Maybe this is a little in the weeds, maybe you don't have the answer, but the objection I've heard to this one is, so I'm just wondering how this is going to actually work, is that tying the rebate tying the cost sharing to the actual negotiated amount would violate trade secret. And so like, how, that's the objection I've heard. Like, are you all prepared for that sort of?
Yeah, we are prepared, and there is an FAQ at the end of the slide deck where it is actually addressed. I'm a clinician, so I could read it to you, but yes, I think the short answer is yes. Yes, that has been something that's been contemplated, and the powers that be feel as though there's a methodology for that to occur.
Fantastic.
And certainly within the spirit of trying to say anything that benefits the member, and there's not a lot of people that are objecting and saying, I want the patient to be gouged. You know, it's like direction, but like how do you navigate those laws? And
Right.
again, there's an FAQ and I have Tracy here, so.
Thank you so much.
Oh, is there another question?
Okay, great, yeah.
Second, from a business perspective, you know, we design our contracts and there's, you know, drug costs are based on spread or pass-through pricing. There's all these different models that seem overly complicated and rife with, you know, potential abuse or misuse. And so, as I suggested, the whole idea here is just to move from cost based on negotiated discounts to actual cost, fee-based, dealing from the pharmacy pricing. So if something's really expensive, that's been a point of contention in the past. There may be the argument that, well, PBM is decided to put a higher price product on because you make, that's out the window. And we're all about the lowest net cost, which I know we've always been, but maybe sometimes the optics of that doesn't appear as that it comes through, but I know that's how we've always had our mission within our organization.
Oh, no, sound is out again, I'm hearing. Others experiencing difficulty with the sound? It was one of the devices in the same room.
Sound remains good for me.
Okay, thanks, John. I think we'll keep going, to stay on track and.
Okay. Yeah, and one of the things I like about this too, you'll see, it's talking about transparency reports and, you know, we're talking about not only transparency reports for customers who we always open our books to, there's always dialogue, they always have accessibility, but then also creating reports to patients around annual patient savings reports. And that's something as a consumer, you don't really see, like it's kind of hidden to you. And so this will be an opportunity to communicate to customers about you pay X amount, you saw this amount of savings and discount. And I don't think that's always clear from a patient perspective. And then pharmacies, again, enhanced compensation for pharmacies so that they're made whole. And we also want to build not on just talking about a dispensing model. We want to also encourage pharmacies to get involved in the care plan, get involved in vaccination programs, increase adherence. That's the number one reason you see a caregiver is that you go to a pharmacy. And anything we can do to partner with them to improve costs and benefits to patients and members, that's a great thing. All right, keep rolling and I know we're getting kind of tight on time.
Also, I mean, I'm just gonna have to call this out. This actually like addresses most of the complaints that have been leveled at PBMs. When is this? And I haven't, have you been
It was announced in Q3 last year.
Q3 last year?
Yeah, and it was ahead of all the federal regulations that happened in December.
Okay.
We were before that.
And so when is this new model? Okay. all right.
So much better. I have noticed it is.
For you to talk slightly louder, we're getting a few comments, sorry.
Okay.
You're so
soft
you're so
spoken,
calm and
just
soft
soft
spoken.
yeah.
Sorry.
Andy, if you direct your speaking to the mic at the front of the room, that would be helpful.
Sure.
Oh, yeah.
And so, yeah, a lot of this is, well, and I can kind of blow through this one, but putting patients in the center of the prescription benefit model so that they understand what their choices are. They have more visibility into their actual out-of-pocket costs. And again, you know, during that deductible phase, that becomes a real problem for patients in the beginning of the year. When sometimes they just go without because they can't afford a medicine. And that's not beneficial for anybody, not for the patient, not for the customer, nobody. It's just wasted cost.
I said the company has moved to this right now, so I can see this as like in real time as a student employee. And it's really cool because you can see like the good RX and Trump RX and what your copay is, what the negotiated rate is. And then, you know, you're going to the pharmacy counter and paying the lowest of all of those.
Yeah. So why don't we move to the next slide? I think that's a pretty good visualization. Yeah, so here, this is kind of getting to the point of the lowest cost to the member, because this has always kind of been like gymnastics for both the pharmacy and a member, where they go to the pharmacy and they hear what the cost is. But now they've got the PBM negotiated price, we've got the cash discount price, the direct-to-consumer price, the patient co-payment. And in today's model, the member might get any of these, you know what I mean? And so they don't like, just give me the lowest price. And so we've been putting a lot of investment in our technology and our systems to present to the pharmacy what the lowest cost is, and that's what gets presented. So there's no extra steps needed, and it's just, that's the lowest price, and this is the, you know, the best value that the member would have as they process against their pharmacy benefit. And so I love that message, because I think every patient that has benefits expected get the lowest, right? That's your expectation, and like this is negotiated, this should be, you know, the best value. To the next slide.
So I ask a quick question here. So we've had folks from the public talk about, don't forget to keep your eyes on premiums, because even though that's not, you know, the prices you pay at the counter are really important to folks. There are other folks who are concerned about what's that ongoing monthly cost.
Right.
So going back to that last slide, if the patient's paying $20 instead of that 25, how are we thinking that's going to load back on premiums for employers? How do we think it's going to affect healthcare costs? Do we expect premiums to go up?
We're not expecting premiums to go up. Like we're expecting this to be kind of the same as like the world we're in now. You're just paying low cost all the way through versus them getting a rebate check at the end.
Okay.
And then our negotiated rate would be different too. Okay. You know, so we're not, you know, that's kind of what we're telling all of our clients. We think this model is going to be the same.
Yeah, you kind of see where you're going though too, because what you're saying is like, wait a second, it was paid before, but now that's $5 out of the pocket of the client. How are they supposed to absorb it? And maybe it was just, I know where it's, why don't we move to that timeline? Because I think that's a pretty helpful, it's the new key.
Oh, the pharmacy.
Maybe go to the next slide.
Okay.
I want to be aware of your time constraint on this one, just make sure we're keeping it on task. So what we believe is that there is a way to aid patients at the point of service where they pay less, and the discount is passed directly to them. We believe that there is a way to keep the customer whole, so their price is at least neutral, if not better, with increased transparency and auditability. And we think there's also a technique to aid pharmacies and compensate them more fairly, so that they feel like they're being made whole for not just dispensing fees, but also their broader range of services.
And in this new model, it's acquisition cost plus a dispensing fee plus a performance fee. So they're going to be made whole because they're going to be paying what they pay for the price of the drug. And that part is beginning transitioning pharmacy model. They contacted them in March of this year and said, some information.
Right, that's actually.
Need some information from you. So that's kind of, that process has started to begin. We're contracting directly with pharmacies on what is your acquisition cost. And let's say then you'll get the dispensing fee, and rural or independent will get a higher dispensing fee than, you know, chain drugstores. And that's all kind of part of this new model.
And this is kind of the timeline. And as you can see, you're kind of asking like, wait, we haven't heard of this before. We made the announcement last year, but there's a ton of recontracting that's involved in this. So number one, we need to upgrade and enhance all of our systems so they can do the things we're telling you that they're going to do. And by all accounts, internal stakeholders are saying, we didn't think we could do this, and it's working. So that's good directionally. In terms of, I think your core question, how are you going to pay for this? A lot of it is through our negotiations with pharmaceutical manufacturers. And as we know, in the current environment, they've done a lot of things to try to keep those prices down for members during the deductible phase. You'll see these, hey, go ahead and it'll be only $100 over the deductible phase. If they could get out of that business and we supported it directly, they love that. You know what I mean? They don't want to have to do all this extra like work. And so if we think there's a partnership where we work with pharmaceutical manufacturers to gain alignment, where that value gets passed to the pharmacy, patient, and the customer. And so there's recontracting that will go on with all of the pharmacies that we negotiate with. We're recontracting with 3,200 of our current customers that are in place.
Yeah, about a third of our book of business is up every year.
Right, but that's a great, so you can't just flip the switch overnight, but it's a recontracting base. It'll take about a 3-year cycle. The first customer that is all in on this is Cigna, the health plan, who owns Express Scripts. So we're going to test it on ourselves. We're going to be the first large health plan that will institute it on 1/1/27, about 2 million lives. And then to Tracy's point, over 2027, that's where we're going to be encouraging more clients and customers to sign up for it. They're going to want proof points because the same questions you have to sign up for that unless I actually know it's going to generate all this value you're telling me about. We're going to be using our 2027 case study to jumpstart all of our new client renewals. And our goal in 2028 is by the end of 28 that we would have roughly 50% of our clients in this model. So this doesn't mean it's the only model. We think it's the future and we think it is the model that would make the most sense. But you need to get some experience with it first. And if it gains traction, we could see those numbers continue to escalate. And as always, with whatever we do, it's a client's decision. So we would offer, here's the current way that it's done. Here's the new enhanced model. And the client or customer will make the decision for how they want to make it. I think that's kind of how we always operate. So I know you're asking about timeline. Hopefully this gives you like at least kind of a timeline for that visibility. And that's thank you for the generous use of the time. I apologize. I think.
Well, this was helpful.
I'm sorry, I'm so curious. And maybe this is again, like beyond the scope of us being able to talk about, but the one thing I didn't see any information on is how do you think these new models are gonna affect like formulary placement and access? Because, you know, when you think of things like Medicaid, those patients don't have cost sharing, but boy, do they have trouble accessing some of their meds because of formularies. So I'm really concerned as a patient advocate about access to, you know, certain meds. And we know that sometimes they get placed because it's the better negotiated price versus like a clinical benefit for patients.
Well, all I can tell you is the current model that we have at our organization, so I can't speak to how everybody else does it. It's always clinical first. So if there's something that has a material benefit to the member, that is a medicine that's necessary on all of our formularies. And in fact, it hurts us from a negotiating perspective because if I have an egregiously expensive medicine that is even incrementally better than something else, it's mandated in all pharmacy formularies. And those manufacturers are incented to probably not provide much of a discount at all. So I can tell you from a patient perspective, it's always clinical first in what we do. From there, if medicines were deemed to be equivalent, then it becomes a lowest net price and then how it benefits the customer and the member. So that's always the model that we follow. And that's how I would address that.
Thank you.
And just another couple of quick questions. So this model will be able to be compatible with ERISA plans and Medicare pricing regulations, things like that. And then finally, is this just Express Scripts or do you see the other PBMs following suit?
So I'm better equipped to handle the second question, not the first. And I do think,
We're following all state and federal laws and this complies with all of them. So yeah.
Everybody needs a Tracy. Yeah. But what I can say is this is just Express Scripts. This is our presentation about where we're directionally heading. But it's a pretty bold move. And we feel like if it gains traction, there will be a lot of followers. And I don't want to give you the impression that our competitors haven't ever contemplated versions of this also. But this is us really putting our foot forward and saying, we're going kind of all in this direction. And we hope and believe that this may be that gains more and more traction over the next 20 years.
Oh, well, you paying close attention. Yeah. Thank you. Yeah, that was helpful to understand.
I guess the only final thing I'll say is that it's risky for us. You know what I mean? Like,
Well,
Everybody follows the phrases that it's like,
that's, in this,
and we're
in
tearing.
a healthcare system that is, you know, in a financial model that we have, to go out and be the one that takes the lead comes with risk.
Absolutely.
I mean, you could attract a higher risk pool but it, you know, you're talking about the points that have been the major concerns, you know, and I've said many times, I'm a capitalist myself, you know, and I don't mind people making some money, but you have to deliver the value that's commensurate with what you're bringing to the marketplace. So this stuff, very interesting.
And I just want to say, you know, to your point of risk, like if this model is what's going to get implemented, you are taking a risk. And I think as someone who has a lived experience as a patient, that's always in my mind. What I'm always pleading for from companies is take a risk to do better for patients. So I'm excited.
right.
How many, if any of these were changes were required under the settlement of the government?
Well, we announced it before that settlement and we drafted that settlement to be very close to this model. So I think the only thing that was, there's a couple of things that they put kind of a finer point on, like we have to put Trump RX as part of our offerings and like the having the things that you see as a patient. And then our GPO had to move from Switzerland to United States. So that report purchasing organization now is going to be based in United States.
Prime Therapeutics with Marcus is up.
Well, good. Marcus Crusoe with Prime Therapeutics, working government affairs. Been with Prime about 8 years, on and off like 12 years, numerous positions. For this current position, I was within network compliance. So I can address some of those questions just based on knowledge that comes up. If anybody's got any questions. I'll speak specifically just to what Prime is, give kind of a highlight of PBMs in general from a Prime perspective. And then I think one of the asks was what the board has been doing and what we've heard in past presentations that we think is a good idea, or maybe not necessarily a better idea, but additional idea to that. So I'll go through that. I'll try to be as quick as possible. So who we are, we're owned and governed by not-for-profit Blue Cross Blue Shield plans across the country, 19 total at this point. Not a single dollar we make goes to Wall Street, which is a big thing that our CEO is very much proud of. That's the reason we have this partnership with them. We're very much aligned in our decision-making, putting the needs of the patient first. And we're proud of the fact that we look more into the shareholders as far as, not shareholders, but the stakeholders being the patients. Yes, no, Brody slipped. Yes, stakeholders being the patients, the pharmacies, everybody involved within the entire process. So very much clinically led services. So we have a clinical team. I think sometimes people forget that when they hear PBM, they're not really sure what a PBM is. We have doctors, we have pharmacists. These are people that understand the industry, they understand the patient. So it's not just a bunch of, people talking hot air going in there and all the bad things you hear at the different government things.
Can I direct your voice?
Sorry. Quit looking at me. Look at this. We focus on appropriate medication and care navigation. So again, working with the health plan and their clinicians, as well as our clinicians on our side and the pharmacists. And overall, work to lower net pharmacy costs. I think that's really the purpose of all the PBMs, is to negotiate those lower drug prices with the drug manufacturers, to make the best informed. And I know it was talked about before as far as how those decisions are made with formulary and with our P&T committee. Again, the first thing that comes that we take into account is the clinical viability of it and efficacy. We don't look at price at all within our P&T committee. So after that, whoever wants to make those decisions, they can make those decisions. But at Prime, we do not look at price at all. Next slide. So what is a PBM? So a PBM manages the drug benefit for the members across the board. So you got your health plans, your labor unions, Medicaid, Medicare Part D, direct to employers, which might be like the University of Minnesota, which is kind of like on their own. So we would work directly with them. One thing I think of this, I don't think anybody's ever seen the movie Son-in-Law, but there's a scene with Flea, who's a tattoo artist. And Becca goes in to get this tattoo and she's trying to decide what tattoo she wants. And he just looks at her with a blank stare and says, "You pick it, we stick it." That's kind of how PBM works with all these folks. So it's not like we're telling them you have to do this, you have to do this, you have to do this. We're saying, here's your options. You pick it, we'll stick it, we'll implement it for you. So at that point, it's very much, there is that relationship with those health plans and those employers, but they're working with other people to consult with. So they have their brokers, their pharmacy management consultants, and all these other folks that are helping them make these decisions. And then they come to us and they have all the artillery they need when they come to the negotiating table with us when we're working with these groups. So I know in the past, or what you might see is it seems like there's a disadvantage, and people are saying, well, they don't know well enough the PBM steering here this way or that way. It's not the case at all. They have the resources. They make those decisions. We implement it for them. Next slide. Who the different people we work with, the entire supply chain, really, the plan sponsors being, the health benefit plan and or the unions and employers, the pharmacies, independent and chain pharmacies, the different drug manufacturers, the patients and members. We have, if there's an issue that comes up with a patient's benefit, they call the number on the back of their card and it goes to our folks with their member services to help them with that, as well as medical providers when they're working through utilization management. So what services do PBMs offer? I mean, this is a lot. And I kind of touched on it before, but the administrative services. So when people go into a pharmacy, they go in there with their healthcare, their health insurance card, and their thought is they're talking directly to their health insurer. What really is happening behind the scenes is the PBM is processing that claim. So all that information that's showing up on that screen of what the cost is going to be to the member at that point of sale and everything else is generated by that PBM that the health plan utilizes. So it's really the PBM working directly and communicating directly with those pharmacists. So if there's really any question that comes up, that's who your go-to is for that. So the administrative services, just processing those claims in general, applying it to the accumulators, et cetera, that's all done at the PBM level and falls under the administrative services. Benefit design support, again, call out in consultation and collaboration with the plan sponsors. This is when, again, our clients get what's called a benefit edit tool, where they're selecting, this is what we want, this is what we want our co-pays to be, this is what we want for utilization management, we want prior authorization here, we want step therapy here, the whole list of things. They're picking and choosing what they want. Again, pick it and stick it. They pick it, we're going to stick it with consultation with them and their outside consultation. Pharmacy network management. That's where we set up the different networks. So you have your specialty networks, you have your retail networks. There used to be a day, I think, when there was like 10 networks total within a PBM, and now there's hundreds, if not thousands, of different networks because each different state has their own, or each different client can have their own. So the thing that we offer to our clients is an opportunity there for them to really develop these different networks. And then as legislation gets passed and now it's law and regulation, you're forced to make these new networks to be able to operationalize these changes that are implemented by the state and federal government. Formulary and rebate administration. Again, what I talked about the P&T committee, how we work with our clients and how it's purely based on the clinical findings and then pass on to what we think, how it would be tiered. And then the rebate administration is where we negotiate those specific rebates with the drug manufacturers and with the negotiating power to get a higher rebate that we pass through straight to the client. So again, you'll hear things, and I think in Minnesota it's already law, but you'll hear things where people say the PBMs just want these rebates so they can pocket these rebates. It's not the case. We pass all of that back through to our health plan so that they can manage overall drug healthcare costs. So it's not limited to however they want to spend it, whether it be on their inpatient issues or inpatient costs or their drug specific costs. We don't know and we don't care. Here's your money. This is what we negotiated. We're taking those rebates. We pass all that 100% right back through to you. The clinical programs, utilization management, I talked to that as far as our clinicians that work along the lines, working with our health plan partners as well on prior authorization, step therapy, et cetera, specialty drug management, compliance reporting, audit support. That's another thing where when we sign these contracts and we go out to RFP with these different health plans, these different employers, we're saying we're going to be compliant with all state and regulatory laws. So they know that they're kind of putting it to us to take on that responsibility. So we continue to do that. We give free, not free audits, but we allow them to audit us at any time. So if they have questions, and when I worked in network compliance, I also oversaw the audit portion, and our clients are ruthless. I mean, they want to dig into every possible thing they can, and we're happy to do it, and we explain everything. And if they have questions, we're an open book. So I think that's one thing that Prime does as far as a PBM offering. Next slide.
Sorry, Marcus, could I ask one quick question? Kind of going back, if we could go back a slide.
Yep.
I just want to ask a question about the formulary and rebate administration.
Yes.
It sounded like you were saying, but I'm not quite sure if I understand that the formulary placement decisions are made separate from rebate amounts you get, or is there a wall of separation between that, or is there a correlation between how much a drug is rebated and where it gets placed on a formulary, or is that your client's decisions?
I don't know for sure, so I'll have to come back and give you that answer. Okay. I know from a Prime perspective, I want to make sure I don't know if you know for sure off the top of your head, Hannah.
Well, we don't decide any formulary placements. Those are all handled by our clients. They decide formulary placements, but they will look at the rebate amount that they get for drugs in their formulary placements.
When you say our client, talking about the health plan.
That's our health plans, our employer groups, our labor unions, anybody, state of Minnesota, because we run the Medicaid program too. So,
yeah. So they're going to be presented with a menu of options. Here's the different, I see.
Yeah.
Okay. Thank you.
And the prime difference, again, I talked about this on that first slide, the governance by nonprofit blue plans, which are accountable to members, not stockholders. The evidence-based clinical expertise guiding coverage decisions. Again, this goes to our clinicians within the utilization management areas. Very often, if I have questions about anything, I go straight to our CPMs, our clinical program managers, which are extremely intelligent people that will tell me everything I know and don't need to know about a drug. And it's very helpful from my standpoint. Helping patients access appropriate, safe, and affordable medicines. Again, there's a number of different programs that we have in place. One is, I think it's a newer product that we just started, I think like 6 months ago, Advocate Plus, where it's actually like a bidding opportunity for pharmacies for the more expensive drugs. So they go on to this site and they're able to say, we would take this reimbursement for this specific drug for this patient. And then whatever comes out as the lowest one is the one that we go with that bid. So they know exactly what they're going to get reimbursed as the lowest cost to the patient for that specific drug. Our product team is, product innovation team is constantly coming up with new products. So there's more to come on that. I didn't bring a product person here, but if in future ones you want to hear more about Prime products, I think we can arrange that as well. Visibility into cost and financial trade-offs. It's kind of what Hannah had just spoken to before, as far as the health plans and our clients being able to see what their decisions, what the implications of those decisions are when it comes to formulary placement, et cetera, as well as when they negotiate with us as far as what we're going to get from a rebate standpoint. And I think with Prime, one of the big things that gives us the negotiating power to get these higher rebate from the drug manufacturers is the number of people that we have. So when you have the 19 non-for-profits, it's 20+ million people. You go in there, you're having those negotiations. That's why it's so important that you have volume to negotiate. So next slide. So this was what I was talking about before, as far as the considerations for PDAB. I think based on what the prescription drug transparency was, I think it was Trump's first term in 2020, If the law requires drug manufacturers, wholesalers, and PBMs to report specific data. It does not require drug manufacturers to report all drugs. It does not include reporting requirements for all drugs supply chain members. So what we would recommend is bringing that same data that's required of the PBMs, the manufacturers, the wholesalers, to all drugs for drug manufacturers, as well as including pharmacies and PSAOs to be included within those reporting requirements. I think in order to make a fully informed decision and ensure you're taking everything into consideration, you have to have all the data. And if you don't have all the data from the people within that supply chain, you're going to slim your chance of being able to come out with, I think, a successful plan going forward. Another issue that was brought up, and I've heard it a couple of times from, I believe it was the drug manufacturers when they spoke, but UPL, we would say that to not move forward with the UPL because it's going to create a drug shortage and access issues for members. And when I say that is if you're saying that you set an upper limit in the state of Minnesota and they know that it's $1,000 drug and they're only going to get reimbursed $500, the drug manufacturers can recognize I'm not going to target Minnesota anymore because they're not going to be able to buy those. They're not going to want the drugs here. We're going to pivot to another state, and the pharmacy's not going to want to supply those drugs because they know they're not going to get that full reimbursement of what's worth. So they're not going to sell it. They're not going to buy it. I think when you set that upper payment limit, it's going to hurt the patients more than help them. And I think one of the I know there's some like physicians and clinicians in here. What is it? The Hippocratic Oath is do no harm. So I think when you look at the UPL and creating UPL, while well-intentioned, I think it would do more harm than good. So I would recommend that.
Can I ask a quick question? So one of the things we've been doing is trying to talk to everyone along the pharmaceutical supply chain to really get informed, right? And we have heard from people saying that, oh, you put a UPL here, maybe manufacturers won't sell or the pharmacies won't buy. Can you just lay that out for us a little bit, how this would happen? Because I think for a lot of us, we're trying to imagine how a manufacturer would just sort of shut off the spigot to one state for one product. And you guys have such a deep understanding of this system because you're embedded in a lot of these transactions. Could you kind of spell out for us how that would happen?
So if a drug manufacturer had, I'll make up a drug, 41. There's a drug called 41.
Okay.
And they know that it costs this much for research and development, however much it costs to create and dispense across nationwide, that it's going to cost them $1,000. And there's an upper payment limit set at $500. So if the pharmacy decides to carry drug 41 and the drug manufacturer sells that to them, and I think at the highest price they could sell to was for $500, right? So you have the upper payment limit. There's no incentive anymore for that drug manufacturer to stay there with that specific drug. So if they have all the resources, nationwide of where they want to dispense these drugs, and now they can say, we don't need to insert any of those resources, time, or money into the state of Minnesota anymore for this specific drug. We're going to pivot and go somewhere else.
Let me vary your scenario.
Okay.
Thank you.
The cost to the manufacturer is $100. The state of Minnesota says, we're going to put an upper payment limit. You've been charging $1,000. You can only charge $500. Are they still going to move drugs out of Minnesota because they're only going to make 5 times their cost?
That would be a great question for a drug manufacturer.
I mean, this is an incredibly bold statement that you just put with a period at the end of it. UPL will create drug shortages and access issues for members, period. We were created to do cost reviews and determine whether there was affordability challenges, and if so, to create a UPL. So, I mean, you're going to get a little pushback. I mean, we have, the feds are instituting maximum fair price. Manufacturers are putting their drugs out at that fair price. That might be that's too bold a statement. Manufacturers have been providing drugs at the first round. They're not gonna run if we stuck with that. We're gonna look at the market and be careful.
But I also kind of want to add to that, like as someone who has a lived experience, losing a child and working to develop those drugs and being a patient advocate, helping people get access to medication. Like, I see the harm right now of some of these drug prices, day in and day out. I see people losing their homes, mortgaging their homes and doing GoFundMe. So, I mean, I appreciate your comments, but that feels, I don't know, like I feel like, you know, the Hippocratic Oath, using that, it feels a little bit reductionistic, right? We're all here to do the best so I just.
I'll just give it another perspective. And it's just, and it wasn't based just solely on what I had said, it's because I heard it in previous ones. So I'm not the only one saying it.
And I think something to keep in mind is, you know, Minnesota's not the only PDAB, right? Colorado also has a PDAB, and they have tried to already start upper payment limits, and we've seen where that is right now. It's tied up in a lawsuit. They're being sued by the manufacturer. So I think it's maybe not full on, you know, let's not do this, but maybe pause and see how those lawsuits kind of shake out and how that ends in Colorado before Minnesota pushes forward doing their own that may also be tied up in a lawsuit.
Let me just comment. We've had upper payment limits on generic drugs in the Medicaid program for 20, 30 years. Those manufacturers didn't stay out of the Minnesota market. They didn't stay out of the national market. There are upper payments limits that are used and effective in the market and haven't eliminated manufacturers from entering the market. So how would a manufacturer prevent a pharmacy from buying from a wholesaler in Iowa or Wisconsin instead of Minnesota?
Say one more time.
Is there any drug that a manufacturer has ever eliminated from one state only? Can you give me any example where that's ever occurred?
That was kind of what I was sort of getting at.
I can't give an example of a specific drug.
It's because they haven't done it yet.
Well,
Can I add one quick thing, which you don't need to answer now, but it sounds like maybe you were sort of suggesting maybe you'd be open to giving us data, maybe? You talked about missing data along the supply chain.
No, so
You already reported.
we already
Yeah, we already reported.
You don't have the entire supply chain.
Yeah, I mean, I think I've seen the data that come to Commerce and they're pretty high level. It would be lovely to have some more granular data from you guys if you're willing to
when we
share.
enter into any of the drugs to do a cost review on,
Will come.
you know, I've mentioned several times, I would encourage everyone in the industry to share data with us so that we can understand. And if, you know, if the data shows that, you know, setting a UPL would do harm, we wouldn't do it. But we need that data, and we're kind of blind right now. So we're not going to pause. We were given a charge. We were appointed to pursue our charge. Telling us to pause is, you know, that's we're pursuing our charge. We were appointed to do this. We're going to keep working toward it as we get to our cost review. If you have better data than we have access to, I would encourage everyone in the supply chain to share that with us and help us understand. We're all actually here because of a lived experience that has brought us here. We care deeply about the patient experience. We are responding to some very real issues in this segment of the really complicated healthcare system. And appreciate getting people's perspectives, but when it boils down to this is going to do harm, that's not our, that was a job for the legislature and the governor. They created us here to do this work, and that's what we're doing.
They pick it, you stick it.
Yes, that's right.
And just a reminder, the PBMs report to the Department of Commerce, but the PBMs also report to the Department of Health, along with the pharmacies and everything, wholesalers, not the PSAs.
Okay.
And which leads us
Great.
to
PCMA.
I'm Michelle Mack from PCMA, the Pharmaceutical Care Management Association. And I have Johnny Garcia. Unfortunately, he wasn't able to make it here, Dr. Garcia. So he is going to do the presentation, and I will turn it over to Dr. Garcia.
Hey, good morning, everybody. Can you all hear me okay?
Yeah, you're coming through great.
Okay, great. Just wanted to make sure. So thank you for taking the time to speak with me this morning. My name is Johnny Garcia. I'm a pharmacist. I've worked in pharmacy for 26 years now. Started off as a technician working for a major retailer and worked my way through pharmacy school and everything. Worked for major retailers for about 10 years. Did my clinical rotations in rural areas of New Mexico. Went on to mail order pharmacy, trying something different. At the time, it was evolving. And then in the specialty pharmacy as well, where I managed and was the pharmacist in charge for a location that had 750 employees that mailed out to national patients throughout the U.S. And then shifted gears, worked with the boards of pharmacies on the regulatory side, and was a lobbyist, and now work for the PBM side. So kind of been around quite a bit, seen all the different aspects, definitely recognize my colleagues that are here today, as well as everybody else that's either a patient advocate or a pharmacist in this industry. It's ever evolving, as we've already heard, and it's pretty exciting to see what's coming. But here to lend kind of an open view of everything. I think a lot of the stuff that I've got in my slides have already been presented by some of my colleagues before, so we may go a little bit quick and save you guys some time this morning. But with that, I'll go into the next slide. So as Marcus was talking about, PBMs offer a lot of different things. I think, we get shoved into a space of being a middleman, sometimes somebody that's skimming off the top. That's not necessarily true. As you've heard, we're hired by employers, unions, government programs, and insurers to administer the drug benefits. It's not a requirement, it's something that is a market offering so that people have a drug expert on this side and the insurance side to help negotiate drug prices down. We do that through a bunch of different tools, negotiating rebates and discounts on brand drugs. I think we've talked about that already. Contracting with retail, mail order, and specialty pharmacies. Sometimes they are owned by the PBM, sometimes they are not. As you heard in the first presentation, independent pharmacies are integral into our networks. And there are times where we negotiate with the PSAOs, the Pharmacy Service Administrative Organizations that represent those independent pharmacies directly. And there are times where PBMs will negotiate directly with the independent pharmacy as well. Process and adjudicate prescription claims. That's been around for many, many years, since the 80s. So I think most pharmacists here know what that is. Formulary management, prior authorization, step therapy, and patient safety. Like my colleague said, this is typically blind to cost at the beginning. It is a clinical decision to start. The clinical decision comes through the P&T committees, where the group of clinicians, pharmacists, doctors, nurses, look at the medications and all the data that's out there, making sure the drugs are being dispensed appropriately for the indication. And then after that, they make recommendations whether to include the drug or not include the drug in a decision-making process. And then it moves on to the PBM, where they look at that and determine whether there's any rebate availability on those drugs, and then allow the client to make the decision on whether to place that on formulary or not. I heard that question earlier. Hopefully that covered that question. Value for patients. PBMs look at all the claims that come through. So as long as a patient is using their insurance coverage, going through the PBM, we can identify drug interactions and medication errors. It's very exciting to see that some of our members are moving into those cash paying programs and trying to capture some of that data, because it is also going to help with the drug interaction and medication error side. Home delivery, specialty pharmacy coordination, whether that's through the ones that they own or outside. We do have PBMs that use pharmacies that are not part of their ownership. So you could have somebody that, like, I'm going to say Prime Therapeutics, because they're there, maybe using somebody like Mark Cuban's good cost plus program pharmacy for cheaper generics. So there's a lot of coordination on who can offer the lowest price. That's something that the PBMs do. Programs for patients facing high cost sharing. There's a lot of financial incentives and programs in specialty pharmacy specifically that help reduce the cost. There's financial programs through the drug manufacturers, or sometimes foundational assistance programs offered through the specialty and mail order pharmacies as well. So by the numbers, in the state of Minnesota, there's approximately 55.2 million prescriptions processed last year. So quite a few prescriptions moving through your state. 90% of those or more could be generic drugs, and that's preferably where the PBMs want us to be. Those are the lower cost medications, obviously, and been around for quite a while. For about every dollar spent, there's about a $10 savings. So looking roughly about $145 billion total value. And on average, PBMs save about a little over $1,100 per year for patients. And then plan sponsors, it's a broad term, but that's really just employers and stuff. We offer all the things that we've already talked about earlier. All right, next slide. So I want to spend a little bit of time kind of just talking about like the landscape, the state landscape, where we are with costs, talking about specialty. So you'll see that in the next couple of slides. But health spending is projected to grow by 5.4% a year, and that's pretty large. We're talking, millions and billions of dollars here. I think the most astounding thing is that when you look at drug pricing, and often PBMs are blamed for the cost of drug pricing, we're trying to negotiate those prices down. And from 2008 to 2021, you can see that the median cost of a prescription drug went from $2,000 to $180,000. I mean, I remember working in retail and having $4 generics available on the market. That list has dwindled significantly because drug prices just continue to go up. And everybody's evolving around that. Specialty pharmacy, a lot of discussion about specialty pharmacy and what specialty drugs are. They account for 54% of total drug spend, but only about 3% of volume. So it's a very small amount, but because they're so expensive, they're taking up a lot of that drug spend. And so you're seeing the market shift in ways to try to get some of these specialty drugs covered without increasing premiums or increasing cost share. New brand name drug prices increased about 20% year over year. That's from the time that they're introduced. From the research portion to the time they hit the market, it's about 20% increase year over year. In 2020, you might have seen this already, 45% of Minnesota residents worry about the cost of their prescription drugs, and 1 in 5 are rationing drugs. That's very scary, especially for patients that are taking insulin products or things that are similar, just to ration that and trying to determine whether they want life-saving medications or can afford the costs. So that's where PBMs are really looking at programs, as you heard in the first presentation, to help reduce some of these costs. And every state is looking at ways to reduce drug costs. This state and this board is charged with trying to reduce drug costs, and definitely appreciate that.
Could you share that with us?
I'm sorry?
I haven't seen that study. Could you share that with us at some point?
Yeah, absolutely. So it's a hyperlink here, but I can get you the information.
And these slides, all 3 presentations will be published to our website, and I think that hyperlink should be live on the website too.
It should be on check.
Yep.
Yeah.
Okay, if there's any problems with it, please let me know, and I'll get you a copy for sure.
All right, thanks.
Next slide. So I want to spend a little time talking about specialty pharmacies. Having worked in retail and independent pharmacies back in the early 2000s, I think pharmacies evolved. There was a time when, pharmacists played an integral role in getting the medication, providing that access, processing the prescription, dealing with prior authorizations, and getting those out to the patients. I think what we're seeing now is the market is evolving. A lot of this is due to the Hep C drugs that came out in 2014. Where a patient had to stay on the medications. They could not miss a dose. If they missed a dose, it was very expensive. $80,000 worth of medication could be thrown away simply by missing some doses. So that's where specialty pharmacy kind of developed and grew. And in the specialty pharmacies, they're a little bit more of an evolved version of a retail location because they offer a lot more specialized services. I'm focusing mostly on the care coordination section. I think this is where specialty pharmacies differentiate themselves from a normal pharmacy. They coordinate with entire healthcare teams. So these specialty pharmacies have teams of nurses, doctors, pharmacists. You've got technicians, call center reps that are working very closely with the patient's doctor to coordinate the care. So if the patient is on a medication that needs to be administered through IV, making sure the patient has their scheduled date, all the lab values have been received and checked upon. The drug is appropriate and safe for the weight of the patient. For cancer medications, if the patient's lost weight, you can't give too much of a dose. Are there kidney clearance? Everything's there. So these pharmacists are really focused on making sure that they have that information and going through that and making sure it's appropriate for those specific drugs. Medical and pharmacy benefit claims data. You'll hear a lot about vertical integration and plans that are PBMs that are associated with a health plan. This is one area where it actually is very beneficial because the pharmacy can actually see the medical claims and pull in some of those lab values and also determine whether or not the product's cheaper through the medical benefit or through the pharmacy benefit. Quality control measures, making sure that we have all those lab values, as I said, payer and manufacturer reporting. Specialty pharmacies do also help the manufacturers with some reporting on specific information. So if there's REMS data that needs to be submitted to the FDA, that's where the specialty pharmacy may help out the drug manufacturers and provide that report. And then just improved health outcomes. And so the specialty pharmacies are absolutely driving the outcomes, making sure the patient's there. I'll go into the next slide here and show you guys a little bit of how they do that. So the clinical specialists in specialty pharmacy, they're often broken down by specific areas and clinical disease states. So off here on the left-hand side, you'll see some of the different teams. It's not all inclusive, but it kind of gives you an idea of where they are. There are teams that are focused strictly on HIV, on the muscular sclerosis and neurology, endocrine, the blood-borne disorders, and that's kind of where the advanced therapies goes a little bit further. The blood disorders, the hemophilia, immune disorders, rare gene therapy stuff there. So those are highly specialized. Those teams are even smaller and often up-trained into those different therapies to make sure that the patient's getting the best personalized service there. And then some of our PBMs, I forgot to mention, PCMA does represent 20 PBMs ranging from the large ones to the small ones. And we have one member who's strictly a PBM focused on like fertility. So making sure that the fertility medications are received on time. It's very important that timing is everything there for those fertility beds. So an example of what a team would do, just looking at RA and inflammatory, the call center reps would initiate a call to a patient and do a daily or do a screening, and it's a questionnaire asking about their life activities. Are they having a hard time going to the pharmacy to receive the medications? Are they having a hard time even opening the bottles? What kind of things can the PBM help with and coordinate with? Their social workers, everything is at the disposal of the specialty pharmacies there to help the patient with these, including transportation services to get the patient to and from some of their appointments. Clinical contact for individuals with gaps in care. So if a patient is no longer receiving medications or if they're not going to their doctor's visits, how do we help those patients? And then in infusion type medications, we do have nurses that are employed by the PBMs that can go to the homes and infuse medications. We really saw this uptick in the COVID timeframe where patients did not want to go to the hospital. They prefer that the nurses and everybody come to their homes to administer the medications. So lots of different programs through specialty pharmacies. Once again, specialty pharmacies aren't always owned by the PBM. There are specialty pharmacies through hospitals. There are specialty pharmacies that are independently owned. The PBM will work with those specialty pharmacies in their networks if there's a gap in that service to get them as part of the network. Next question, next slide. So I want to spend a little bit of time talking about what's happening on the federal level. So PBM reform is a very big topic, both federal and state level. In January of 2021, as part of the Consolidated Appropriations Act, the feds did pass a pretty large PBM reform bill. And in that bill, they did require that 100% of rebates are passed through to the plan sponsors. So all discounts for manufacturers are there. So you will see PBMs start to reform and change their practices so that rebates are accounted for in contracts and that are passed through to meet the new requirements that set forth August 2028. Maximum transparency. So the requirements of PBMs to provide plan sponsors, employers, reports that are very detailed, that are drug by drug, claim by claim reporting, is now a requirement in 2028 for PBMs. So it's bringing that transparency forward that the market has been requesting. And then Medicare delinking. Delinking is a term where PBMs cannot be compensated for any of their services based on the list price of a drug. That would need to be a flat fee. So that's where Medicare has taken that step and gone to a flat fee arrangement for PBM contracts starting in 2028 as well. Lots of change, lots of movement moving into 2028. You'll see PBMs really change their practices, I think, because of some of the CAA stuff. Next slide. So how do you fit in here? Kind of doing a quick state landscape. I'm sure you guys have already seen this. I've already heard discussions about Colorado and so on and so forth, but you all know you're a board authority. There's 5 states that have upper payment limit authority, Colorado being one of those, highly talked about with their decision to include Enbrel in the upper payment limit, and it's now under litigation right now. States that have study recommendation authority, a few others that are here, a few have been dissolved and some are inactive. But overall, no state has really implemented an upper payment limit to date yet. There are some obstacles in doing that. It may be worth looking into, but it is going to come with some challenges. Next slide, please. So how can you lower drug costs? I think, offering some suggestions as well, looking at drug pricing data, when you guys do get the data, I think there's an often overlooked area here with wholesaler and pharmacy pricing. That drug pricing that starts with the drug manufacturers goes to a wholesaler, receives some sort of either rebating or markup, then passed on to the pharmacy for ultimate sale to the patient. That entire section is often not looked at. And so there are some states that do have some transparency requirements in the New England area that are trying to get their hands on what that looks like from point A to point pharmacy, and seeing where the markups are along for the true markup of a drug price. Supply chain rebates, right now the PBM rebates are under scrutiny, but I think there are additional rebates from the wholesalers to drug manufacturers, as well as discounts that pharmacies receive by hitting certain metrics when they purchase from the wholesaler. There are rebates kind of spread throughout that. Hospitals also receive rebates on drugs. So I think looking at all rebates may be a good place for the PDAB to look. And then really keeping in mind the therapeutic alternatives. So these are the medications, if there are medications that exist, the Humira, Enbrel kind of situations, is there a drug that may be cheaper for a patient to be on, and how do you direct patients to those? That's a common goal that PBMs also have. Reviewing patient access. Obviously, we've got to keep the patient front and center of everything that we do, making sure that we don't remove any access through any of the programs that may be proposed. And then impacts of coupons. What we're seeing is oftentimes the coupons are only available on very expensive brand name medications. And it's driving patients to those because they get an upfront discount, but the patient's left paying, the patient and the payer are left paying for very expensive drugs down the road if the patient starts those medications. And then also taking a look at pharmacy workforce enclosure. There's a lot of studies out right now where there are less and less students going into pharmacy school and into the practice of our profession, and it's creating shortages. And a lot of pharmacies are closing in rural locations because they just simply cannot staff. So taking a look at that from an access in your rural areas as well. Setting upper payment limits, I know it's a controversial topic, but if a drug is found to be affordable, you would set the upper payment limit, looking at supplies, the supply cost, the pricing, and maybe even considering Canadian pricing. Some of the other states have already done that. And then applying to purchases and reimbursements in Minnesota. So similar to the Medicare fair pricing stuff that's out right now, a payer would only pay a certain amount. What that does, however, is it does leave the pharmacies searching for ways to get the additional cost back. So if the pharmacy needs to be made whole in any way, the federal side requires the pharmacy to work directly with the manufacturer to recoup some of that cost. So it does put a little bit of burden on the pharmacies if there is any discrepancy in from what they're being paid versus what they purchased the drug for. So keep that in mind as you work through the upper payment limits. Next slide, please. So you guys know what the upper payment limits are. So it's the cap. Doesn't control what manufacturers charge though. So a manufacturer can still charge that whatever they want to charge, but to the wholesaler, but the pharmacy will only be reimbursed to a maximum amount. So that's going to be oftentimes to the Medicare maximum fair price, the negotiated prices that are happening in Medicare. So, and as I said, no state has fully implemented a UPL as of yet. Colorado is the furthest along, as you're aware. And Maryland just approved their action plan, and they are looking at drugs like Ozempic to potentially put it on there. Drug manufacturers are moving a little bit more into the direct-to-consumer space with some of the GLP-1s, so there may be some opportunities there. We have not really looked at that and how that fits into the market quite yet, but I know that PBMs are seeing if there are ways to include some of that data so that we just capture the patient's claims information and make sure there's no safety issues there. Next slide, please. So just kind of wrapping up here, hopefully saving you some time. Here's our cost savings, about $1,100 per year for patients. Federal PBM reform in 2026 mandates those three different things: the pass-through, the delinking, and the maximum transparency. 12 states have PDABs. You guys are in a unique position to review costs and set up our payment limits, and uniquely tie that to the Medicare fair pricing. As you look through this, and similar, charge of a PBM is to make sure competition exists and remains. So it's the most effective tool for reducing drug costs. The drugs that have competition, the Enbrels and Humiras, making sure that those still can compete with each other so that there's leverage on the cost. Using generics where they exist, you guys are 100% right. Generic market is pretty strong. Lots of players in that market. So making sure that they still remain competitive, and then prices, trying to keep the prices down overall. But overall, PCMA is available as a resource. If there's anything that we can provide or help you with that our members, may not be able to provide, and we can give you a larger industry look at it, we will absolutely provide that to you. So, are there any questions? I know I flew through those slides pretty quickly.
A question around the concept around pharmacy reimbursement. So I have a question. So my name is Matt. I run a community center clinic for people living with that risk for HIV, PV clinic. Just trying to serve folks low cost, no cost, increase access to care. And a year ago, opened a pharmacy. It has been an incredibly painful experience. I'm understanding why there are so few independent pharmacies left. And one of the big killers is the PBM will reimburse us for some medications below what we have to buy them at from the wholesaler. And I'm like, this is crazy. How is this possible? How is this legal? Like, no one's been able to explain this to me. And I wonder, if you guys could help me understand, how does that happen?
Yeah, there's multiple factors, right? And not having access to the contracts myself of what those arrangements are. I think in the first presentation, you saw kind of that cost plus model that a lot of PBMs are moving towards, where the pharmacy will be made whole for the cost of the product, and then receive a dispensing fee or some kind of other clinical services fee in addition to that. I think the market's evolving around that. One thing that I would also say is if that pharmacy is represented by a PSAO, taking a look at those, because there are some chargebacks that the PSAO is recouping from that pharmacy for brand effective rate or generic effective rate contracts, where if the pharmacy is not hitting certain quality metrics or ordering points, they may recoup some of that money. And that's not the PBM, that's the PSAO. But I can say the PBMs are moving into a model where they will look at those contracts more closely, because the rural and smaller pharmacies are becoming more and more critical to our networks. But without having further details, I can't break it down any further than that.
Frustrating.
Johnny, it's my understanding that some PBMs also use brand effective rates and generic effective rates, not just the PSAOs.
How does the PSAO?
No, some of the PBMs use brand effective rates and generic effective rates, just like you said the PSAOs do.
Right, some do as well, because that's trying to drive the market to the lower cost medications. So as part of the quality metrics that a PBM has to be part of the network, and possibly even in the preferred status where we're sending more volume to those pharmacies, we may use a generic effective rate or a brand effective rate contract to get the pharmacies to switch patients to a more cost-effective product. So if the pharmacy is not meeting those metrics, then it is called out in the contract that there may be some cost associated with that for the business.
I just wanted to establish that PBMs do it as well. You implied that only PSAOs do that.
Okay, no, both do. So I do apologize for that. But yes, they are, depending on the contract and the network terms, yes, both do use those to drive people to, or drive pharmacies to a lower cost medication.
All right.
This was very interesting.
This was very interesting.
Thank you.
Thank you all for participating. And
Thank you all.
Please do this. I'm based here in Minnesota. I always have access to Johnny as well. And, we have
these members here, but also all of our members, and we want to be used as a resource and be helpful.
It just, for the UPL part, I think in my slide, I should have put May instead of. No, I was after the fact, because when we started asking the questions, like, well, I should have said May. That's what I think in my head, but it's like, direct.
Legitimate point.
Yes, so just keep that in mind. Thank you very much.
Thank you.
So we're on to the data project presentation. Warren, you want to kick that off and just turn it right over to Steve, or?
I will, Steve, you're gonna show your slides?
Yeah, and did you get on that?
I'll go ahead and turn it over to Steve, and then I can fill in some things at the end as well with in terms of things we're doing from an implementation standpoint.
Take me a minute to get.
Or it's just.
If anyone needs a little. I don't really.
I had realized that I mean, I've read about it. I've read about these changes. Heard somebody from the PBM talk about it from their perspective. It's kind of interesting. I don't know how effective it will be, but it's.
Point out they're proposed, they haven't,
Proposed,
I haven't
yeah.
seen them implemented in yet, so.
Maybe I'll take this minute and just cover something that would come up later in the agenda. The June meeting, I can't remember what the date was, but it no longer worked for too many of our members, and so we're canceling that meeting. We have scheduled a July 2nd meeting within our group that we have enough participation with. So we will be doing that. We will have to do it as a special meeting that will be published and go through, James will be back and will help us through publishing that, but just stating publicly, our next meeting will be July 2nd, a Thursday. So we'll take care of that part of the agenda right now during this little.
I've got to let Steve in here just a snack.
And then we're gonna have trouble with mics again.
Andy was speaking very soft.
He was. And we got him to talk toward the camera. I think that helped.
Say, John, so Steve is not admitted in the meeting.
Who has to let me in?
Not showing anyone waiting.
While we're working on the Badger stuff, any updates on the legislation, construction advisory process?
So the PDAC, the legislation that would eliminate the PDAC did pass the Senate, did not pass the House.
Was it up yet? Or has it been voted down, or is it just waiting to be taken out?
I believe it's been voted down, and now we're in a spot where you have to, the two houses come together.
It's not in the conference, so it's not in House bill, it is in the Senate bill.
Did any commerce, is it going to conference? Is it commerce? I understand it passed the Senate in a commerce omnibus. Did the House vote down the entire commerce omnibus such that it doesn't go to committee, into the commerce committee? I think that might be the scenario, in which case there's not really any longer a venue for.
Josh is saying that it is in the Senate Commerce Bill, not in the House Commerce Bill.
Okay, so the House passed the Commerce Bill, but stripped that out of it.
Yeah.
Okay.
Is Steve, you're still not able to?
I re-entered and it still says the same thing.
Do you have that on a flag? I can grab this flag, try.
Here, I'm good enough. Maybe another update we can do, Tony, is in terms of calendar. So we do not, we have a July 2nd meeting, which is our June meeting. We still need a July meeting. So coming out of this meeting, I'd like to be able to pull you all and look at the last week in July to be that July meeting. And then for August.
And the July meeting would be our annual meeting.
Our annual
where we
meeting.
Go through.
Yeah.
Elect a new chair too, and I'm termed out based on our, so, you know, just a, you know, or a.
You got reappointed to two, you got
Erica and I, our terms are up, but.
Crowded fields.
In 4 more years.
So does that mean that we'll have 2 meetings in July?
Yes. That's the goal. We still have to find that second date in July that works for enough people.
And then August, what we've discussed and some of us is we still have to finish our work on the governance quadrants and the handbook. And so in our smaller working group, we've discussed having a working session of the board in August at some time, 2 to 3 hours. Not an official board meeting per se, although we'll have it open. If 4 or more of us show up, we'll have a quorum. But that would be, instead of taking kind of like half-hour chunks of time to try and go through this and put it all together, a longer period of time seems to make sense. So at the same time, I'm finding time in August for that kind of working session. And then in terms of the rest of the year, I think we need to wait on people getting their teaching schedules.
For the August meeting where we're gonna do more on the governance, I would suggest we work to make sure that we have a time that we'll have a quorum and that quorum can take action.
Okay.
And if we don't have 7, that's okay. I mean, I personally, if I wasn't able to make it, as long as, you know,
Okay.
Matt and Erica were there who have been working on this, I have faith in my colleagues here. We've been working with each other enough. I would like to see that group empowered enough, make it a public, you know, you said it was gonna be a public meeting.
Right.
Make sure we have a quorum. And if 1 or 2 members can't make it, you know, buy into the governance that comes out of that session. That would be, otherwise we gotta bring it up again. You know, and
we can always amend stuff afterwards as well.
Yes.
So if someone sees that there's a critical and deadly flaw in it, it's not like it's
right.
set in stone.
Right.
Yep.
So
that'd be my.
Okay, no, I think that makes sense. So we'll have to find a date where there's at least 4 board members.
And then for September forward, you're saying, wait till, you know, there's 3 members that teach.
There's 3 members that teach.
Get your, you know, fall schedules and then we'll coordinate.
Yeah. I don't know that I know my.
I think so. Didn't see that.
So let me.
You think it's. We don't need people to teach, right?
To see?
I'm definitely asking you to come to a guest lecture. We have to. Guest lecture at some point. So
Very
we're
good.
ready. Yeah, should we have to?
I've asked you, sure.
I can tell you what I was scheduled from last year, which is pretty good. It's Monday and Wednesday afternoons.
Starts classes. We do it for, right?
Saturday. We're on second. Let me make it. Just so I have.
Great way to start a conversation. We're all listening.
The mics are on.
Okay. All right, we're good. Great, so, this is just for discussion only, a starting point.
Steve, I wonder if I could get you to come back here, because then you can see and speak directly to the speaker.
But I need to control this.
I'll grab your home office.
Okay, we'll go right and on.
Then you'll be speaking into the speaker.
We'll move over as soon as this is.
Okay.
So this is just a starting point for where we're at. Let me remind us, as this slide shows, we're at the top level, the green bar. There's 100,000 national drug code products on the market. That's everything. So nothing's been selected at that point, right? That's the whole market. That's where we're at. So we're going to talk about ways to go through the next steps. The next step is just a broad affordability screen. What's anything that anybody's ever whispered affordability to? Just anything. And looking at the list that have been published out there by Department of Health and other people, I estimate there are around 10,000 NDC codes that will be on that anybody mentioned it anywhere list. So that's the first. Then the third stage is at some point we need to boil that down to a smaller number, maybe plus or minus 100 drugs, NDC codes. And that will give us something. Then we can discuss those and look at those and say, how do we decide which ones to focus on and what priorities to have? At some point, we need to narrow it down to drugs that we're going to do cost reviews on. And then we only choose an upper payment limit if we've done a cost review and consider it to have a significant affordability challenge. So at first, we're just saying, is there any hint of an affordability problem? And then we're saying, okay, there are more significant concerns for this smaller set. And then we need to decide. And I've arbitrarily picked the numbers. We can make those anything we want. 100, we could make it 50, we could make it 500. At the end of the day, we need to say, how many are we going to do cost reviews on? We're going to do it on 10, we're going to do it on 2. Most of the PDABs have done 1 to 5 in their first round to do cost reviews on. And then they decided for some of those to do upper payment limits. So this sets the overview of kind of where we're going. And then I'll talk through processes.
I'm going to interrupt.
Yeah.
Where would you put Medicare fair pricing lists in that breakdown?
That'll come up.
Okay.
It's not necessarily on this breakdown. We need to decide. Certainly they're in the blue bar.
Yep.
They're in the green bar. They're in the blue bar. I would negotiated prices probably fall within the purple bar, the middle one.
Yeah.
And then we can decide if any of those fall in the orange or red bar.
Do we have to do a cost review of those? Or does the legislation basically say we can skip the cost review process because Medicare has already identified it?
Excellent point.
Okay.
I think basically both the legislation and one can argue that Medicare has done a cost review and negotiated the price with the manufacturer to a reasonable price. So both Minnesota statute as well as federal statute and process have done cost reviews on that set of drugs. So in a way, that would be a good starting point because it's already been done. In fact, those have been tested in the Supreme Court as well and upheld that the government has a right to do that. So it, I wouldn't say totally avoids, but it limits the legal challenge. They've also done the intensive work of doing a cost review and realized they had a team of tens or hundreds of people doing cost reviews on all of these drugs and working with manufacturers. We don't have the resources or staff to do that. So I think we should, if at all possible, if we agree with that approach, rely on the work that's already been done and build upon it.
And the only reason why I'm saying that is so that we could end up in a situation where the 3 to 5 UPL selection could actually be more than that
if they're already done,
if it's already done, we get so yeah.
They're pre-done.
Yeah.
That, yes, you could do more if it wasn't as labor intensive.
Right.
Yeah, good point. Other questions, thoughts, comments on this? This is kind of the funnel process we've talked about. Boiling it down. Yes.
Yeah, just kind of one quick question. I hope it's not off topic, but I also look at this as about cost, and I'm wondering about where we weigh the needs of the many and the needs of the few. So I can see where thousands would want us to look at GLP-1 drugs with Wegovy, Ozempic, and the cost reviews and concerns there. But there may be, 5 to 10 patients with a rare form of epilepsy that need an $800,000 drug that's clearly out of reach. How do we balance the many versus the few when we look at this?
Let me answer your first question. When do we do it? And then how we'll have to address as a group. Okay? But when we do it, I see that coming from the blue bar to the purple bar. The blue bar is just the big fishing net, everything's in. The purple bar is where we start to say, what are we going to focus on? And going from the 10,000 to whatever the number, 100 or some number smaller, begins to weigh the few versus many, the many versus few. And maybe we end up with some of both. But that's a decision that comes between the blue and the purple bar. And then that issue continues to be relevant at each level after that. The orange and the red level. And that's a decision we have to make as a group. That's not a decision that's anybody's made yet or plans to do, but we need to do and develop out. So when from blue to purple is where we started, how we'll have to work that out.
I think you were talking today about some of the variables that we need to weigh to determine.
We'll come to that,
Yeah.
some potential variables, and there may be others. that we
Exactly,
want to
some
bring up as
potential
well.
variables, and that'll be,
Yes.
yeah, that's our work.
That's our work. That's why we have a PDAB instead of just a market that isn't working. I always like to remind us, I'll do these quickly. What does a statute say we're supposed to do? First of all, it says PDABs to identify prescription drugs that may impose costs that create significant affordability challenges. And it uses the word significant affordability challenges for the state healthcare system and for patients. So in addition to many, few, many, we have the state health system and patients both on the table, and relatively, at least in the statute, and parallel. We have to decide how we implement that and how we interpret that. Related topics, that statutory authority we have for the PDAB. I'll move this. Closer. Oh, I want to move this.
Oh, I'm sorry.
I can't read the slide.
I'm sorry. I thought you were wanting to advance this.
No, I
apologize.
So in the, as the PDAB, remember the green to the blue, the wide net is anything that's considered unaffordable costs of certain drugs, I think is in our scope. But then for prescription drug product reviews, here it's called product reviews, but that's also the cost reviews. And when we get down to the cost review level, then then we get down to drugs that have led or will lead to affordability challenges for the state health system and the patient again. So again, that's our charge. So let's look at this. As I started looking for where can we find lists already created. These aren't Steve's list. These aren't anybody. Well, other people created the list, but these aren't necessarily my list. Oh, one other thing. The state also in statute said that the Department of Health has authority to collect data from drug manufacturers, and that they are to do that to support the PDAB, among other things that they do with it. And when they do collect data, they're to supply it to us within 30 days of receipt or whenever we request it based on it. I think one request we should give to the state to the Department of Health is, which drugs have they collected data on from manufacturers? I'm not talking just general public data, but which drugs have they collected data on? So we know what they have.
Under section 62J84, so it's not all data that they get.
No,
It's
so
data
where did they
for-
collect
what-
it here?
Yeah, what is 62J84 subs 3, 4, and 5?
I think that's the price transparency.
That's what I thought.
It's
That's what I thought.
everything they collect in the price transparency law.
Yep.
So we should ask them for a list of those drugs by molecule and by NDC. So we know what they have, what data they have and how to access that. And then the statute also says the board, PDAB, may subscribe to one or more prescription drug pricing files. And it specifically names Metaspan and First Data Bank as the first choice. And there could be others, it says, or, others determined by the board. So that's kind of where we're at. What is out there and what could we use to help us? So as far as data sources, the first one, the one mentioned in statute, is Metaspan. Metaspan is a database that is created. It has pricing, but it only has list prices. It doesn't have transaction prices. It doesn't have market-based prices. It only has the list price, the AWP and the WAC. Those are necessary. The one thing Metaspan does for us is it has a comprehensive set of the NDCs. The 100,000 NDCs, they have all of them listed, and they have descriptive information about all of them. Which ones are brand versus generic, which manufacturer makes it, when was the drug approved, how long has it been on the market, is it a biological product versus a traditional product. It has lots of descriptive, what I would call as a researcher, sorting variables, things to help you analyze and group your data into various sets. It has the structure to show which therapeutic class and they belong in. And we could group them to say, let's look at all the multiple sclerosis drugs or all the HIV drugs or all the GLP-1s. You can group them by, So it's just a very handy, it's a tool that you need kind of to manage drug databases. Virtually every pharmacy in the country in their computer system has Metaspan or First Data Bank, one of the two, and has that information. And every PBM uses it, every manufacturer uses it. It's kind of universal in the industry, is the backbone for the database system. So it's kind of it just provides general descriptive information on the drugs and the starting point, the WAC, the AWP, and the WAC. And it shows, the other thing I remind us is drug prices can change frequently. Every day of the year, some drug somewhere in the market has changed the price. Any given drug typically will change the price 1 to 4 times a year. So if we have a database and we have prices, but the database is now 3 years old, it doesn't have the current price. And
if we buy Metaspan, does it update?
Well, you that's part of it, the subscription. You get, you could buy a monthly subscription or a real-time online. I think for the work we're doing, probably monthly is sufficient. But you can get real-time if you need to.
Why does the price change so often?
Because they can. Manufacturers change. If you could set your salary, would you change it often? Okay. So that's Metaspan. It's a backbone. It's a descriptive characteristic database. And we could choose Metaspan or First Data Bank. The state uses Metaspan for their APCD. They use it for the work of the Price Transparency Project and other things. Another database that we will use and can use is the Minnesota All-Payer Claims Database. They use Metaspan as one of the tools to help them manage the All-Payer Claims Database. The All-Payer Claims Database is claims processed in the state of Minnesota by health plans and by PBMs. And I forget, we'll have to ask the Department of Health, but I think about 50 or 60% of the claims in the state come into that database these days. Health plans and PBMs can choose not to submit their data. And there was a time when they first started, they had about 80–85% of the claims in the state. But a number of PBMs and others have chosen to withhold or not submit their data to the all payer claims database.
ERISA, those preempted.
Well, ERISA's a lot of plans. Yes.
ERISA's a lot. Yep.
So a substantial share don't submit their data anymore. Some do. There's still more than half, I think, of all the claims in the state, but it's not a comprehensive data set. And it doesn't include cash pay prescriptions. It doesn't include prescriptions that might be processed by things outside of the normal channels.
But one thing to know is that MDH, they told me they do have ways and methods to try to deal with some of the lost claims from the APCD. That is something I guess they have thought about.
With the missing insurance claims, they don't deal with the missing cash pay claims.
Cash pay, no. But missing, yeah, missing drug claim, yeah.
Cash pay.
And,
Also,
and there's a lag time too.
yes, right?
Yeah, and
Yes,
there's a
there is a lag time, and for many things, all payer claims database is essential and gives us tools we don't have. And when it comes to looking at current pricing, it's not current pricing. It's going to be 12 months, 18 months. We'll have to ask them, how frequently, how recent they can give us data, but it'll be somewhat out of date. But since our principal issue is cost and affordability, recency kind of makes a difference, because especially if they're going up 4 times a year. And if we're 12 to 18 months out, they could have had 4, 6, 8 price increases since the data was submitted to APCD. So that's one issue with it, is recency. It does give us Minnesota specific data, and we can also find that in other places. So that's all payer claims database. What I would say is they've already produced a number of reports using the statutory criteria, and here are drugs that have exceeded the statutory criteria. And I would propose, in a minute, I'll show lists that we should incorporate, and I would propose we use all the lists that APCD has already produced and that the Transparency Project has produced. They give us signals of products that have exceeded the standards set by the statutes. And so they should be on our list, at least from the blue to the green bar at least. And then we can decide which ones to keep on as we go further down the line. So we have and will use the APCD. I'm not arguing against not using it. I'm just arguing that there may be other things we need to use also to fill in. There is such a thing called Medicare Part D public use files. And, the statutes didn't say, look at affordability for everybody except Medicare. Medicare is in our scope. It shouldn't be our only focus, but it is in our scope. So Medicare, and likewise, Medicaid state drug utilization data sets are available. And also, I believe does Market Scan have Medicaid and Medicare?
Not specifically for Minnesota.
Not, okay, not Minnesota specific, but they do nationwide. Yeah. So there's Medicaid data, and remember, one of our charges was affordability to the patient and the state healthcare system. So Medicaid is part of, not all of, but part of the state healthcare system. It's a big expense item in the state budget.
Except those aren't the actual prices Medicaid pays. Those are just the gross prices. The list prices.
Exactly.
But utilization, but not all the utilization either, because it'll be all the 340B drugs won't be in there.
Right. So we have ways to catch that, or ways to address that. The next source is what's called IQVIA. Used to be known as IMS for those that have been around the industry for a long time, but IQVIA, this is a data set. This is the gold standard used by drug manufacturers to track their drug and how much they're selling and what their prices are. It is fairly, you can get data within a week of the prescriptions being paid typically, or within a month for sure. IQVIA has many things that some of these others don't. IQVIA has the list prices, but it also has transaction prices, or at least a step toward transaction prices. So it has, and it has the amount the consumer paid out of pocket versus the amount the plan paid if it's insured. IQVIA can also break down what was the price paid by cash pay consumers versus the insured consumers versus Medicare consumers versus Medicaid consumers. So it can break it down by payer type.
How do they capture cash pay, I wonder? Do you know? I mean,
Yes, IQVIA, this has been in operation since the 60s at least, and since we started computerizing pharmacies. They capture when a pharmacy fills a prescription and sends it off to see if it's covered by a third party. They send it to what's called a switch, and then the switch sends it to the PBM. IQVIA captures the data at every switch in the country, and they get about 90+% of all the claims transactions, including fast pay scripts.
but if I come in and say, I don't want you to look at my insurance, I'm just gonna pay, I'm cash pay, do they still put it through that?
Cash pay is captured on there as well, yes. It's all captured. So they have about 90% of the claims in the market. The ones where they're weakest is they don't have claims processed in hospitals or inpatient. And the mail orders owned by the PBMs haven't always shared all of their data with the IQVIA. They get some of it, they're getting more of it now and more PBMs, and there's more of the mail order that's not in a PBM owned mail order also. It's in Amazon. So they have more of it, but they're a little weak on mail order and they don't have virtually any of the hospital inpatient claims.
Hospital outpatient, like if I'm getting an infused chemotherapy in like a clinic, would they have those kind of buy and bill drugs?
Well, it depends. They will have hospital outpatient clinics, the pharmacy. They'll have hospital, like Fairview Pharmacy down here on University Avenue. They'll have those, but they won't have what the provider billed, the medical provider billed on the medical benefit. They only have the claims billed on the pharmacy benefit, but not billed on the provider benefit. So if a doc just administers a vaccine to a patient in the office and bills the medical insurance plan, that doesn't show up. If you go to the pharmacy and get your vaccine, that shows up.
But to size, like infusion, cancer treatments in an outpatient setting, is that billed through your pharmacy benefit or?
If it's well, it could be either. There are some drugs that are billed in medical and some in pharmacy, some that could go both ways. Many of them are on, I can come up with a list and tell you which drugs aren't included in any of these databases. And APCD does have medical claims data, but they don't often. I analyzed for them back about a decade ago, how much was being billed through medical claims and what the costs were, but they haven't updated that analysis, I think. But it's theoretically there. It's still out of date, but it's theoretically there. And we don't have that other places easily.
Does Metaspan have inpatient?
Metaspan doesn't have any, it doesn't have transactions. They have all the drugs.
They have the drugs. Yep.
But they don't have prices, transaction prices.
And they don't have utilization either.
They don't have utilization, right? Utilization is only from IQVIA or the Medicare and Medicaid, or one more we have common.
APCD.
APCD has utilization, right? A little bit out of date. Although the market's moving fast sometimes. The GLP-1s that we hear about, I'll just crazy say, the GLP-1s that we hear about 3 years ago, we didn't have any claims at the university. And now 3 years later, we have double-digit millions of dollars spent on it in 2 years. So in the time lag that APCD has, we wouldn't even see those drugs yet.
Yeah.
For the most part. So
To solve the problem of getting both N and P in the same place in the same time period, which is hard. But yeah, it's gonna come from different data sets.
Well, IQVIA has, theirs is all consistent. And IQVIA did clarify, IQVIA their primary clients have been manufacturers, and they charge them millions of dollars for their database. It scared us, and sometimes people don't even ask them about the data, but they have set up several years ago a government service unit that focuses on providing data to government agencies, both making it more accessible and more affordable. Is that word affordable to even government agencies? And they assured us that their pricing is much different and much better. We haven't gotten one yet, but we're working on getting a price quote. I think it is in an affordable range, but we'll have to validate that.
Can we set an upper payment limit on them?
We can. They'll set it up or lay it on data. They have made progress. No, I agree. Affordability is an issue for data as well as for drugs.
Steve, they also said they can kind of right size it.
They can.
In terms of if they come back with a quote, we can more narrowly focus what we might want or need from it and make it smaller. We can adjust the price. Very flexible.
What would be the adjustment? Trying to
Number of drugs.
number of drugs. I was.
That is going to potentially be some.
Could we limit it to Minnesota transactions? We don't need your whole database. We just want.
Yeah, they can limit it to Minnesota.
So they can give us, but here's the thing with these big national databases. They're used to running their whole platform and they have all their data, and it costs them more to pull out the Minnesota data than it does to give us the national data. So just because we ask for fewer drugs doesn't mean you get a lower price.
That's what I mean.
It
Yeah,
doesn't
whatever
work
that.
that way. It's easier to give you the shelf. Okay, Craig, do you have a question?
Yeah, just a quick question. So the IQVIA database, does MDH or the state of Minnesota currently have access to that? It looked like Metaspan and the others were available to us now. Is that one available to us through any mechanism with the state of Minnesota?
Not that I'm aware of. We can check. We can also ask the unit at IQVIA if they're selling it.
I don't think they are, because they asked us what it would take to become a vendor.
Yeah.
And one other thing, we do not currently, as the PDAB, have access to Metaspan.
Even though the state does elsewhere.
There are other state entities that do, and we have to continue to try to work with some of them, but we do not, as the PDAB, have authority to access Metaspan data currently.
And so, Tony, if I remember our enabling legislation, if MDH has access to Metaspan and we have access to MDH's data, then by proxy, wouldn't we be able to access Metaspan?
I think that.
Greg, I like your thinking, but the contract between MDH and Metaspan doesn't say that.
And yeah, I mean, it would be a bridge too far to say that we have access to MDH's data. I think if MDH were here in the room, they would be like pretty upset about us. We can ask them for analysis and reports from their data, and they are statutorily required to do certain pieces of that analysis. And we're working on what that might look like with them. But access to their data, to data housed in MDH is not something that we have established to date. It'd be great. I mean, maybe all of these are works in progress. We need access to data to feed, Joel and the MD and the U of M contract that we're close to signing. So I don't know, is that helpful or is?
Yeah.
Well, I agree. I think there's some shades of gray here, and if we're talking to MDH about how that gray comes down to black and white between us, I'd sure be happy to be part of those conversations if helpful.
Yeah, great.
That's great.
He's disappearing, so I don't know, we need to get our. We need to get the guy back there. So the next, there's another database called Meritive. This used to be known as TrueVin, or it's had several names over the last.
It's still market scan.
Market Scan is the database itself. And Market Scan is also a nationwide database. It's largely commercial insurance. Do they have Medicare and Medicaid in there?
Yes, here's
All use
sample. So there's the commercially insured sample, which is the largest sample, about 30 million people. And there's also a Medicare supplemental file, with 5 million people in it per year. And then a Medicaid population, which has about 10 million patients.
All right. And it has transaction prices. It will have consumer out-of-pocket costs. They can give us Minnesota-specific data as well.
For the commercially insured sample, yes.
Not for the Medicaid and Medicare.
Not individually identifiable at the state level.
Although IQVIA can do that. Okay, so there's some overlap between Meritive and this. Meritive probably does have a smaller, less of a universal sample than IQVIA. So they're, although Meritive's pretty good estimated nationwide. So do you know what percent of the market they claim to have? We can find it out, but it's less than IQVIA, but it's in the 60–70% range probably of claims in the market. So that's the Meritive databases. Then there's manufacturer reported data, which MDH has collected. We need to ask, in addition to asking them for a list of the drug molecules and NDCs, we should ask them for a variable list of the types of data they collected. And I think we could ask for that under our executive privilege and not in the public domain, but it may be public too.
Much of that will be trade secret, would be my guess.
Well, the data is, but the variables names themselves.
Yep.
And we need to, in planning our data process, we need to know what specific data points they have. So we need to ask them for their variable list, and if they have a variable definitions along with it would be handy.
Well, I'm going back over a year when we were getting started. We were looking at in one meeting.
They have that presentation.
They have an entire booklet that's published on there that describes what they're requesting. And my recollection is they told us.
I'm on their website.
Yeah, this is how we define what we're requesting.
Yeah.
And the submissions are quite variable.
So we need to have a working session with them to say,
yeah,
what does this say you get and what did you get?
Yeah. That's my recollection going back.
Yeah.
The way it is.
So that the manufacturer, but that's a resource we have, and we need, and it's in statute that we should have it and access it, and it can be very helpful. It avoids us having to go to manufacturers and ask the same thing. We don't want to duplicate work, and the manufacturers probably don't either. Then there could be other drug supply chain and data cost sources that we could go to, but we got to go full with this list probably anyway. So we need to talk through, and I think we use everything we can. We need to look at what is the cost to us. I do think that Metaspan is unique, and I think Meritive and IQVIA are unique. They're somewhat similar, although I would argue IQVIA is superior in several ways that are more valuable to us in the long run, because it's a broader, it has the cash pay customers, it has 90% of the market instead of 60–70%.
So,
and more breakdown of by payer type and other things.
So maybe this is an oversimplification, but it seems to me there's 3 data sources that we should be considering purchasing, and that would be Metaspan, Meritive's Market Scan, and IQVIA. We don't have quotes on what any of these 3 would cost. We were working to hope to get some quotes on them. And Meritive and Acuvia seem like they have overlap. We probably wouldn't buy both.
They're not complete overlap. You probably
Not
don't need
complete overlap, but we probably wouldn't buy both. If we were to buy IQVIA, we wouldn't buy Metaspan, Meritive. And, but you know, by the same token, if we're gonna buy Meritive, it's because its price point is cheaper than IQVIA. And that's the data set that we're gonna work with, that smaller data set. That's sort of how I've put it.
We could get by with it. We need to look at what we give up data wise to do that.
But not having Metaspan, it seems, has
It's a
separate, unique cornerstone. And we thought we were gonna have a bid on that. Maybe we could, I would personally kind of like to set aside the Meritive IQVIA purchase authorization from the board till a time when we have the two quotes and we can decide what are the limitations, we'll know more.
Or can we look at our budget and say, how much do we realistically think we could spend on data and authorize the executive director to use that to get the most value he can with those resources? And if that means getting all three, fine. If it means getting two, we'll have to live with it.
One point that's come up as I've had conversations with board members, Steve, talking about this very issue and some trade-offs, is what we spend on data, we're not able to spend, say, on patient outreach or on staff support. And so I think there's still a little bit of sorting that needs to go on. But I think, to Tony's point, I think Metaspan is table stakes. We've got to have it. And so I think if we can establish that and then look at what's remaining in the budget and make a trade-off between what we spend on IQVIA versus Meritive versus what we also allocate to some of our outreach activities.
And outreach activities too. I mean, honestly, it might be another FTE or more FTE supports to help us.
Yeah, so that's, it could be staff, it could be, there's some conversation about a contractor who maybe is more directly able to help us establish these kind of forums and attract patients as opposed to a staff person. But I think what would make sense and would be timely is probably in a June timeframe or early July timeframe, a conversation with the leadership team and go through some budget scenarios and what would be different, what trade-offs would look like.
I think what would be great is to have cost estimates for all these different things we want to do, and then basically just do the kitchen table budgeting, like what's possible.
We also need to have a clear understanding of the differences in them, because they aren't exact. It's just like drugs. You know, you may have two drugs in the same therapeutic category, but they aren't exactly a fair trade-off equally. And so both could work, but one works better than the other, perhaps. And so we need to understand what we're trading off.
But can I just say one thing, because I know you have your hand up, and I'm just ignoring the chair's prerogative. The thing that is true, though, is that we do have some lists to start thinking about. They're not the lists that we would love to have in expectation when our process is humming, but we do sort of have a set of things that we can start putting through the funnel to get started this summer. And so this decision about how we spend and everything, just for the public, right? It's not stopping us from starting this work. It's sort of,
Not at all.
Not at all.
In fact, I would point out, we have the data we need already to go from the green to the blue. Okay, we have lists. This data we're talking about getting to help us do whatever level of cost review and prioritization we're going to do, and characterizing how many patients, and even for the few, how much does it cost them? And that data we don't have, and it isn't publicly available, and it isn't available, it's only available primarily in Meritive and IQVIA with some supplementation from other places. But we have to have one or one of those two at a minimum to do any measure of a cost review. And or the wild card is, what does MDH have in the manufacturer reported data, and which drugs and what data do they have, and how complete is the data? Remember, we have the list of variables, I agree, Tony, but they may not have answered all of those variables.
Right.
And so it may be unpopulated in their database.
Anyone looking for that on the website, it's their form and manner.
And they list it all out, it's all,
And then it's,
Yeah.
Yep.
So that's it. So this is data, and we need to work through that data. It's an iterative process. I think we'll get the quotes, and are we working on those?
So we were supposed to have a Metaspan quote today and we don't.
Yeah.
We should be getting it in a day or two. We do know Meriton, right? Jones, about $10,000. IQVIA, we need to get them the specific, the specs of what we would be looking for them to give us a real quote.
Yeah.
To that plan, I recall last month we talked about requesting that data from MDH for Jardiance so that we could see what all they have available. Where are we at with that?
They do not have that data. And as I understand it, Jardiance is new enough to the marketplace that
they have not.
they don't have it, hasn't hit their radar yet in terms of.
Could we pick something else on their list that they do have just to see?
We could try, sure. We
Yeah.
could,
To figure out what's, I've downloaded some of these data sets that they have before, trying to see like what's in there from like a public standpoint, but for some reason I'm having trouble finding it. But the form and manner is up there with like a pretty detailed, essentially what I would call a code book here. It's just a question of which drugs, and I can't tell that.
Well, we can look at their other published studies, and I pulled all those and looked at them in this process. And we could look at all the drugs they've already studied and pick one out of it. They have not, they're in the process of doing the Medicare negotiated drugs. Now, they don't, it's not at a point they can release anything.
For their drugs of substantial public interest.
It's their newest drugs of substantial public interest. But they aren't at a point to release anything.
It's on the website.
It's up there now? Did that get released?
The Medicare, the MDH drugs of substantial public interest with the MFP drugs is on within.
But I guess they don't have
The
the
drugs are listed, but not the prices.
Yeah. They have.
That's cost savings. I guess maybe it's.
So that's the Medicare cost savings. Talking about from MDH, did they collect data from?
I'll send an email to Vernon.
Okay.
I think you have lost.
yeah. So maybe one, on this point, and we can start talking about list. If we could get a meeting to the leadership team to go through, we'll have quotes. We can go through budget, we can look at trade-offs between patient outreach versus data and have maybe come to that July 2nd meeting, these, yeah, this one service.
Do we feel if Metaspan, I'm gonna come, if Metaspan is sort of like a foundational data set, and we are, I understand like days from a contract with U of M, and we want to give them access to tools that they can start the work on this contract. Would it make sense to approve a Metaspan purchase up to an amount, and then again come to the July 2nd meeting with a lot more information about market scan, IQVIA, and which one or both makes sense? I don't feel we're ready for that conversation with the information we have to present to the board today. And I do have a pretty strong bent toward making sure that these decisions that cost a lot of money actually come before the board and stand for a vote. At a steady state, at a future time, we will know more about where we're going in a particular year, and we can set an annual budget and then only have the, variances presented to us. But in this time when we weren't sure what it was going to look like, we still don't have quotes. We've had so many questions.
The one thing to note about Metaspan and why it might be fortuitous to vote on that today is that up to some limit, is that that would be coming through Odyssey funds. So
Yeah,
it would be
yeah.
kind of money that we didn't use before, and I think that maybe puts it in a slightly different, like an ongoing.
Right, and so, right, it's not gonna affect our 27 budget. We'll have to make a determination based on what net spending is, how sustainable that is on a go-forward basis, but that gets back into the trade-offs of spending money on data versus spending on staff, that type of support.
And well, we try to work on interagency agreements and things too, to
Right.
gain access through some other purchasing entity within the state, universe.
And the other thing is, so this contract for Metaspan, if we were to approve this, Minute would actually be the contractor. They control the investment funds. It's probably 3 to a 3 month process for the contracting.
Oh,
Well, it puts us at like September, October, Metaspan. And then I'm stretching it out. It might be quicker, but it's at least 4 months. So the longer we wait, the longer we push on.
So, a quick question. Stephen, do you have access to any or all of these databases through your work?
Well, I have access to Metaspan, but much like,
But not IQVIA or,
well, I have access to Metaspan, but it has limits on the use. I can't just give it to the state to use.
no,
I
I'm
can use
thinking
it.
about this sort of, like we had talked about Giardia and looking to see what MDH has, and if we picked a different drug, could we do a informal comparative analysis, maybe informally through what you have available and decide on which of these databases might be more assistive to us in the work that we're doing?
Well, so I've used all of these databases. I don't necessarily have a real-time access to all of them right now, but I've used all of these, and Joel Harley, who we're working with at the university, has used most of these as well. So, and Saye has used some of these as well. So we kind of know what's in them. I can create a grid for us that shows what types of variables in which database has them and what we would be missing if we did or didn't get a certain database.
that'd be cool.
Because there are some instrumental differences that need to be weighed
Like-
carefully.
And I just think that would be helpful in terms of, Tony's point about large costs, bring it before the board. How's the board gonna, make a decision on these investments? And, we're a little bit at the beginning and maybe we're not able to see the whole picture. I think whatever we can provide to us to help guide us in this early phase of making pretty significant investments in data, I think would be helpful from a board's perspective. The other thing I just wanted to add is about the interagency agreements and the MDH stuff. I understand the complexities that go with that. I used to be an assistant commissioner at MDH myself. I helped to pass the legislation that created the payer claims database. I think there may still be some opportunity to look at clarifying what we can access as a PDAB through state agreements before we go and buy a lot of things. Again, it sounds like some things are in process and that's fine. I just wanted to offer that perspective.
I think just real quick, with specific respect to Metaspan, we went through this exercise and James talked with the Department of Health General Counsel several months ago about, because that was our first path that we looked towards, was we work off of the MDH's contract with Metaspan. And it was determined at that point that it might be possible, not sure that it was possible, was definitely going to take a significant amount of time to do. I think the question for the board is, in this, it doesn't have to be either or conversation, right? We can start out with our own subscription, and as we figure out a way, if there is a way to connect into another contract, we can move over to that. My concern is that second part is gonna take such a long time that we're not able to move forward into our work.
And this goes beyond just MDH and PDAB. The
Right.
MCAP infused, the multi-state buying group has Metaspan.
Right.
There are other agencies in the state that have Metaspan, and the state's not consolidating the purchasing.
Right.
Now, that's a bigger issue, I realize, and it has politics top of it. We need to encourage some efficiency here.
So let's say we were gonna move forward with a motion to allow the purchase of Metaspan up to a certain amount. What would that amount be? Anybody?
We know what MDH paid for theirs?
Do we know what Odyssey funds we have?
Yeah, we have about $1 million in Odyssey funds.
And when do we have to use that or it disappears?
By the end of the 27 fiscal year.
Which is July 1st.
Yeah, so correct.
Specific IT related things.
It has to be startup IT projects or subscriptions. Just to flesh out a little bit, I have engaged in it to start looking at how we could use the Odyssey funds. I've got a business analyst, and a project manager that I'm working with. And we're starting to scope out what would the IT work be necessary for us to collect data, hold data, use data, but also have a connection. We have to decide, and MDH would have to be comfortable with, how do we get data from MDH or access data from MDH? And so I think spending the money on that IT infrastructure is a good investment for the future.
And it's solid in the scope of what Odyssey funds are set up for.
Yeah. Now, on the other side, there is money there too from a patient engagement standpoint. Think about what are some IT things we could do to better engage patients. Is it a much more interactive website? Erica, it's as simple as Erica, so let's get a Gulf list put together. You don't have a list, a distribution list.
Yeah.
So I think, and obviously we talk about it as a board, but I think we've got an opportunity over the next year to build out some real foundational infrastructure.
And what's realistic over the next month for you to be able to come back to the board and sort of have some sort of price tag for some items?
I thought I was going to have a price tag today.
In Verdant's defense, the challenge is these are huge databases that have lots of options on them. And their question to us is, well, what pieces do you need? And then we're still developing, what are we going to do with it?
Yeah.
Although I have a pretty good notion of it, we need to define which data sets and how we define it affects the price tag that's going to.
Yeah, and I'm asking more on the IT side that you need as far as your data holding systems, these more functional websites and ways to engage the public.
And those are two big, those are kind of the two big things. And it gets back to what we were talking about, the trade-off of data versus patient outreach.
Who can tell us this is, this would be a better system and this is kind of what it would cost to?
In terms of building the IT, that would be our Minute business advisor.
Would they be able to have some roundish numbers by next month?
Probably not on the actual IT infrastructure, because that's going to involve some fairly detailed conversations with MDH. I think they could lay out conceptually what they're talking about. So I mean, conceptually, they're talking about using an existing warehouse that's within the Department of Commerce that would be linked to our SharePoint site. That once everyone has their email address and access, one day.
Overall.
Well, Paul has stepped up for Minute to say, I'll figure out how to get this done. He did the forensics on Tony's, because Tony got his done. Matt, you hit a stone wall.
Me too.
And SIA too. So Paul is trying to dig through the forensics on why that's not working. But yeah, so those are the big pieces. In terms of an overall, I can ask them. I meet with them every Wednesday, and we can start fleshing out some pricing.
I'm just concerned, 12 months will go fast.
Yeah.
No. Three quick things. One, the Minute 3-month contracting for Metaspan, if we can get NDH's contract with Metaspan, it shouldn't take 3 months to be able to say, this is what we need different.
He was, I'll ask that question. I mean, he was, I think without having had the conversation with Minute yet, what he said, Minute typically takes that period of time in a contract. And I'll be honest, I went with the longest time. It could be shorter.
Second is, as I'm comfortable authorizing up to sort of amount for Metaspan, but I'd also like the leadership team and Vern to look at what can MDH do for, not just what can we get from them in terms of data, but what could we say, we don't need to buy the data if you can do the analysis. And if that means we spend $75,000 on an interagency agreement to pay for your time to do our analysis, as opposed to spending $150,000 on a data set and not having the staff to do the analysis ourselves, that's still a good deal.
So,
If that's the price. If that's, yeah, I don't know, but I mean, we need to figure out, I feel like I need to have a better understanding of what could we get from them instead of buying it ourselves? Because even when we buy it ourselves, we need someone who can, do something.
To that point though, Matt, so we've got Joel as a contractor to do our work. I jump in, but what we've talked about conceptually, MDH has in the statute a charge to provide some level of assistance to us.
And I think they plan to provide some level of assistance. I think it's been really hard to get started.
Yeah.
And something that I have been trying to work on is thinking about, could we write something down? Actually, Craig, I just emailed you about bringing you into these conversations. We've had, I think James is sort of looking for some kind of template language. I think they're service line agreement. Maybe that's what they're called. I was calling it an MOU, but something that might kind of flesh out a little bit more fully what's in the statute and kind of a how would we like to work together, and then come to consensus over that. Because I think it's just been hard to get started because they're like, we're here to help you, and we're like, we need help, and it's just hard for us to know like how to line those things
We've
up.
had a hard time in the conversations stating what we need.
Yeah.
And maybe one piece too, so MME might have up to 3 months to actually finish a contract and get us Metaspan data. When Vernon was talking about, an extended period of time to do interagency agreements or whatever it takes to share data, that's like a lot more than 3 months.
Yeah.
To Steve's point, like there's state entities all over the state that are purchasing the same data sets and not coordinating, and that's because the timelines to coordinate are just.
Right, but we do have a statute that says they're supposed to work with us and help us.
Yeah.
And they are doing cost review like activities on prescription drugs to come up with their lists and come up with, it's just too close.
Yeah.
To not be able to find some efficiency and.
Agreed.
Okay. The last point I want to make is I get the sense from this great overview and from what we're never going to have complete data. We're going to have to make decisions in the midst of some ambiguity, we don't know what the cash pay is. We don't but we know enough. And so I think we have to get sort of comfortable with that. And second, that we have the ability for manufacturers or others to send us data. So if we are in the process and saying, hey, we're looking at this, and a manufacturer says, well, you don't have our data on blah, blah, okay, then send it to us. If you think we're making a decision with a blind spot and you can fill the blind spot, then that's your issue or deal with our decision.
And that would be, like, that's a conversation that having with the minute team, recognizing that we are gonna get information from manufacturers, and how would we facilitate that? It could be through MDH, and we could also have our own direct portal for them to do that.
And collecting and standardizing and organizing that data, we have to staff also.
Right.
So it has a cost to us. We can do it, but it also has a cost to it. It's not free also.
Right.
And we've made that point many times. I mean, because we constantly get told, well, this data set's not any good, and this data set's not any good, and this data set's not any good.
I think you should all step back for a second and be like, maybe this is why drugs.
Well, so once we select a drug for a cost review, give us all that information we don't have. That's, you know, I mean.
And here we need to learn from MDAs. What have manufacturers been giving them and what have they not been giving them?
Yep.
Because the likelihood of us getting, we can ask, but likelihood of us getting things that MDH didn't get also is.
Well, July 2nd, you know, the legislative session will be in the rear view mirror. Maybe we ask MDH to come in and really have a detailed conversation, stopping shy of, you know, sharing, you know, proprietary information, but, you know, what are the boundaries here? I mean, I think that would be very instructive.
And with Dr. Farley to be.
Absolutely. Yeah, how do we work together? What does this look like?
So I have one more slide that kind of begins to give us a sense of what data do we need. It gives us a sense of what data might we need, and how would we use it? And it'll get to that, so we can come back to this. Another
13 of 240?
Yeah.
And I think this point has been made in passing, but you know, there's data and there's analysis. And I think as we think about getting data, we also need to be thinking about how are we going to analyze it, and whether that's we do it all or these are interagency agreements where maybe we're buying some staff time from MDH, or I think they need to be talked about and considered together rather than separately.
I think clarifying this, writing down how we will work together is the first step to get everyone comfortable. Because I work pretty closely with Annalisa's Pepper team, and I know they are like really, you know, really expect that they'll be involved in working with us and want consulted. And but I think it's just a question of like writing something down that everyone can agree to.
So first of all, what list do we have already out there? I've actually collected all of these and I'm compiling them in one just master list. This is the 10,000, it's the green bar under the blue bar. But MDH has produced reports on drugs that meet the statutory criteria we were to look at, like have they increased their price more than X%, or you know, does it cost more than $30,000 per year of therapy? They've created a list of all of those. Yeah. So I've compiled all those lists off of their website. They've also produced drugs of substantial public interest reports on at least 5 different reports, and I've pulled all those in. And I've looked, when I say I look at drugs, I look at the number of molecules and I look at the number of NDCs. So the high level, just molecules, and then the detail level, how many individual products. Then the Medicare Part D list with maximum fair prices that Medicare has negotiated already, and that we're told in statute, if there is one, that becomes your UPL. So I pulled those lists in. They've negotiated prices so far on 25 drugs, and they have another 15 in the works, and they've named those drugs. So I pulled those lists. Then I've looked at the Trump RX drugs. Arguably, those are drugs where manufacturers in the marketplace have been willing to reduce their prices. which is what we're talking about when we talk about affordability is, will you reduce the prices? So
They're cash pay prices.
they are only cash pay, but if we happen to set the upper payment limit at the cash pay price, then it could become broader than a cash pay price. Just saying, possibility. And it's a price that they manufacture themselves as
Have said, yeah, I mean.
But
it's a market-based price.
It's a data point.
it's a data, but I think I think if the manufacturers were here, they would say, yeah, we're willing to sell at a cash pay price of this amount because only 8 people are gonna pay the cash pay price.
Well, that's
We aren't
true.
saying this is gonna be the cash pay price for 80% of that drug's market because we would never agree to that.
But they'll say that about every drug we want to lower the price on. If they set it at the
Right.
price they want for that broader market.
Right, but the Trump RX market is so small.
Oh, I agree with that. I point that out all the time.
Okay.
All we're saying is it's not on the list, and it's saying this appeared on the list because it was on the Trump RX. It may also have been a drug of substantial public interest,
Well,
you know.
It may, I would tell you, just looking at the list so far, the drugs on the Trump RX list, they're like the Filene's basement of a department store. They're the drugs that the manufacturer wants to get rid of. They're retiring. They have a new dosage form, a new strength. So there aren't, yeah.
This is Filene's, like, come on, don't be that in my Filene's basement.
But my point is, we can include them on our broader list. They may drop out when we get
That's
down.
all we're saying is right here. These are on our radar.
Yeah, and then I think we need to include the drugs of other state PDABs that they've taken on. That should be in our broader, big list. I think we should include the drugs from ICER that they've expressed price concerns over. ICER is the Institute for Clinical Effectiveness Review, and they do cost reviews of these drugs with much more rigor and detail than we will ever have time or staff or resources to do.
Yeah.
So they should be on the big list, then we'll decide what to do with them. Then I think we need to engage in a bona fide effort to get Minnesota patient identified drugs. That's why we made a motion last time, and we're asking different entities in the state, please tell us which drugs do you recommend we consider? And we should ask the manufacturers, we should ask all the patient stakeholder groups. And Matt would be glad to have HIV communities recommendations, and we need that. And Erica, we'd be glad to have the Rare Disease Council's recommendations. What drugs are on your list that you think we should be putting on here? So, and then we should ask other stakeholders. I have Minnesota patient identified drugs and then other stakeholders, because patients are stakeholders too. All the other stakeholders, what are the PBMs and everybody else think we should have? And this is a positive list. This isn't a negative list. It isn't, don't put this on. We don't want a list of don't do this. We want a list of what's on the list. But, and then I think we should ask the major state health entities, the state health system that we're supposed to look out for, Medicaid, Medicare, CGIP, the Public Health Agency, state prisons, mental health facilities, state hospitals, MNCAP, and other major state institutions that purchase drugs and that are the, affordability to the state that we're also to be interested in. And then any other drugs that are challenging patient resources by whatever means. So this is a all-inclusive, let's keep adding to the list for now. So we're going from the 100,000 down to about 10,000. The most challenging step then is going after that. And here are some potential criteria or data that we may want to have. One, we can look just at the total spend. If we have a drug that we're spending, in Minnesota, we're spending $1 billion on versus a drug that in the state we only spend $1 million on, one could argue that should have some weight. It's not the only criteria, not the only reason, but so high expenditures total might get something on the list. But I would also argue when it comes to drugs, high volume of use becomes important. If we look at the drugs that have the highest expenditure, we're going to see drugs like GLP-1s and Humira and drugs that are only used by less than 2% of the population. But if I look at the list of drugs that have the most prescriptions or most days of therapy, we're going to see atorvastatin, lisinopril, levothyroxine, drugs that are fairly cheap generics, but they're used by 20-30% of the population.
And mental health drugs.
And mental health drugs as well, especially. So volume, so I would argue expenditure is one criteria. Volume of use measured by, I would argue days of therapy or something similar to that. Then high cost per day. You may have a drug that doesn't hit either of the other two lists, although many of the drugs will show up on 3 or 4 of these lists. But drugs is high cost per day. So if we have a drug that costs $50,000 per dose per day, that's a big deal. I mean, that by definition is unaffordable to most people. Do we take that on? And there we get to the many versus few, the few versus many. I would argue, and we need to debate and discuss this, we may want to pick some drugs that meet each of these criteria. And then have some of each type. So we're addressing different audiences in different ways. So then I would argue, we've had people tell us that you should focus on patient out-of-pocket costs.
Yep.
And while I don't think we should focus exclusively on that, that should be one of the factors, and we should know which drugs have the highest out-of-pocket costs.
Yep.
And what is the dollar out-of-pocket cost to patients? And that data is available in some of the data sets that we can acquire. Then I think we need to have Minnesota patient identified drugs. We've had some already in each of our meetings. Each time we've had consumers or groups here, people have raised drugs. And Vernon's kept a list of those. I'm incorporating those, but that's why we're soliciting more broadly from patient advocacy groups and others. Tell us which patient identified drugs we need to have on the list. And this deals both with patients' feelings, it deals with their lived experiences related to drugs, their real life experiences. That should be a factor in the drugs on our list as well. And then I think we may want to include some drugs based on their drug product characteristics. For example, the inhalers have been a category of drugs that they should have been generic decades ago, but they keep coming out with a new inhaler delivery, even though the drug's old, and the prices have stayed really high. And there are some other categories like that, the self-injectable drugs. A drug company will come out with a drug as a self-injectable rather than oral tablet because they can charge more and get away with it. Like the GLP-1s that are now coming out with orals after they've had them injectable for 3 or 4 or 5 years. So there may be certain drugs by their characteristics or drugs for certain patient populations, certain vulnerable patient populations. We may want to focus on certain orphan drugs or drugs for certain rare diseases, or and we'll go to the experts to tell us which ones, what would you recommend and why? How do we justify it? And we may want to focus on some emergency drugs, drugs like epinephrine, the EpiPen, and insulin. Now, both of those have had some effort, and the insulin has been price level. So we could argue we essentially have an UPL for insulin. We didn't set it, but the state did already for insulins. But we don't have it for EpiPens yet.
I wouldn't say with an upper payment limit.
Well, maximum amount out of pocket.
Maximum out of pocket, but that's not what an upper payment, that's, yeah.
I know. So we could dovetail it with an upper payment limit, but at least some would argue there's some measure of affordability that's improved.
Yes.
And EpiPen, and also naloxone is a drug that, since everybody, they're making it available for every first responder everywhere in the world, you can get naloxone, the price has shot up dramatically. And in fact, I remember IQVIA did tell us the one request they had to consider buying data at the state of Minnesota was to evaluate the cost of their naloxone. And the state decided not to pursue the project, but it may be a drug. So and the statutes specifically mentioned in other drugs we should consider and emergency drugs. And we haven't really talked much about that, but that's also in the statute. So there are other criteria. So these, I would argue all of these, it's not a A versus B, it's a and, F and we keep adding to it. Comments on these or other criteria you would add to this?
And so Stephen, I suffer from advanced multiple sclerosis, and there are 15 disease modifying drugs that target different kinds of patients with different symptoms and it's sort of a spectrum disorder. Those drugs range from $60,000 to $120,000 a year in cost. And there's some evergreening in there. Most are biologics, as are a lot of the autoimmune disorders. There's some biosimilars in there. Where would my story fit in your list? Is that a high out-of-pocket cost? Is it a patient-identified drug? Is it some other characteristic? How would you fit that example into this framework?
So if we take each of these criteria and we had complete data on drugs in Minnesota, which we don't, but if we had it and we created a list of each of these, I would argue those drugs would show up on 3 or 4 of these criteria. And they only need to show up on one most. They would be high daily cost. They're among the highest daily cost drugs we have in the market. They would be among the high patient out-of-pocket costs. They would be among the patient-identified drugs. They probably would also be among the drug product characteristics, that is biologics or drugs for patients. They'd be among the orphan or rare disease and or patients of vulnerable populations. So they would show up on most, not all, but most of these criteria. And I'm not proposing that we use all of these criteria. You have to meet all of them to even be on the list.
Well, I mean, maybe it's a weighting, I mean, if you're on, if you meet that criteria, it's worth this many points. And I mean, and we have to figure out how to build that funnel, but I do got to manage time.
Yes.
And we have to do the executive director's report.
Yes.
And open it up for public comments.
If people have comments on these, send me.
Oh, yeah, Matt, you had,
Also,
We need,
okay.
you need sign off to go ahead and work with these lists.
Which list? Are you signing?
To start moving forward. Like what we've
They're
got.
going back to list of
I
these
mean,
times.
yeah, we don't have these lists, but the previous lists of drugs of substantial public interest, the lists that we already have in here.
They're already on our,
Yeah.
I mean, this is just, these are on our radar.
Do we need a vote to sort of start moving forward with
Say
that
it's okay to
process,
move forward using those
bundling those and working on those as our first.
I don't see a motion. I mean, these are all on our radar. I mean, this, the statutory criteria, MDH has provided those that, publicly, the substantial public interest that provide, I mean, like, these have all come to us in a public manner. I think if somebody wants to make a motion, I guess we certainly could vote on it, but I don't believe there's.
these aren't exclusionary either. These are a starting point and we will keep adding to the list. So it's not like this is the list. Don't mention anything else. That's not what I'm saying. We're saying here's the starting point and we need to add that one.
In the interest of allowing us to continue to move forward and not get trapped up in timing, I would make a motion to authorize the leadership team to pursue a Metaspan contract up to $165,000 from Odyssey funds. The 165 is with the notion that we have another $10,000 for the MedSpan, or whatever the one was. 175,000 of the total Odyssey funds seems like a reasonable-ish, seems expensive. I bought it, but relative to our Odyssey funds, seems like it allows us enough flexibility for the other potential uses of Odyssey funds to still be viable, with the idea that we will come back to our second meeting to get an update and further information.
So your motion is to allow the purchase of Metaspan up to $165,000.
Yeah,
To start moving on.
fairly confident we can get it.
That's what
Probably get us to 3 databases within that.
Any further discussion?
I would only want to buy Metaspan when we're ready to use Metaspan. So we're not paying for time where it's not in use.
I think this will, for Joel to get started with the list that we have, we've got to have them.
Yeah, so Craig, to your point, it's gonna take a few months for the contract, but by the time a few months go by, we're ready to do our work. Yeah. Call the roll.
Call the roll.
Craig Acorn,
Yes.
Anderson,
Yes.
Erica Barnes,
Yes.
Tony Laurie,
Yes.
Sia Nickpay,
Yes.
Stephen Chandlemeyer,
Yes.
and Matt Tober. Yep. And seven yeas, no nays.
All right. Oh, let's move on to the executive director's report.
So we've already talked through calendar. Quick recap, July 2nd will be designated as a special meeting. We'll put the notice out for that. I'll poll the board to get a meeting the last week in July. August will be a work session with the goal, not a full board meeting, but the goal of getting a quorum present, so we could make motions and do work. In terms of related to that as well, let me just pull this up. Calendar, but from a different perspective in terms of the work we want to get done. You know what, here, James, I guess James is raising his hand here. Let's let James.
Yeah, James.
This will be an out of order answer to a question because understandably, I think you couldn't see my hand was up. I just want to give a specific answer to something that Matt Anderson asked or suggested during the last discussion. And to know that MDH has done this for us, I want to confirm we did ask MDH several months ago for their contract with Metaspan. And as of a couple of weeks ago, we do now have all of their full contracts with Metaspan. So we will be taking advantage of that.
Thank you, James. Okay. So. Okay, so now this is a translating through. I'll just read it. So we've talked about scheduling the meetings, but in terms of work, so July 2nd, we're going to come back with quotes that we have. We'll have had a budget discussion with the leadership team to bring to that meeting in terms of trade-offs. But I would also like to suggest that we present a draft of selection criteria publicly to seek public comment on it. And that we come back in the second July meeting after receiving comment from the board and from the public, come back and at least consider approving that selection criteria to move forward. The second July meeting will be the annual meeting. We'll do the elections, probably the chair and the vice chair. Again, review public comment on the selection criteria. August, the board work session on the handbook. And then really thinking about what September looks like. Because September, I think, will be a time when we also start to approve moving forward. So let's say we approve the selection criteria. We've done the work to find that criteria. Do we consider in the September, October timeframe actually exposing a list of drugs, condensed list of drugs, meeting the criteria that we might possibly consider? I think it makes sense to explore cost review. Have that in a public meeting. Let a month pass to give the public opportunity to comment on it. Also do aggressive outreach to patient groups to get their input on it. And so that's just kind of teeing up what I think September looks like. We would probably also hopefully approve the governance handbook.
I had one other housekeeping item too, and we've gotten a couple of public comment letters from groups over the last couple of days. And one of the pieces in there that appeared in both, I do feel is worth just talking about. They suggested that we don't put on our website the comments that we get. And we had a conversation about this a long time ago, and it was because, I mean, we want people sometimes share PHI, you know, health information and things that we shouldn't publish. I would like to publish the letters that said, hey, we wish you would publish letters that you got, you know, comments that you got, and just put out publicly that if you want us to publish your comment, say so in the cover letter or indicate in some manner, and we would be happy to. I think though, in a, you know, I want people to feel comfortable sharing their stories with us, and we need to protect their stories when they're private. So I would suggest that we make it a practice to publish if we're asked to publish them.
I support that. We should review with council with James. Do we need a release from them to publish it? And let's make sure we protect ourselves carefully so we don't accidentally release something that somebody else has.
Well, that's what I'm saying. We would, you know, they would have to tell us, we want you to post this. And the last two comments that we got said that we should be publishing all the time. I think that's a, you know, that could get us in trouble. But if you say publish it, we should publish it. We're trying to do our work in as transparent a manner as possible. I would like to be responsive to that point. So that's something people are.
We have the IT system to be able to, I can publish documents. There's an added complication that started in April. There's a new requirement in terms of accessibility of documents that are posted electronically. So we were a little late posting some things in April because we had to go through an accessibility check on all the documents that we posted. So for documents that I produce, or the feedback produces, that's a relatively easy process to go through. Documents that other people produce, it may not be quite so easy. So I have to work with those groups.
Okay. Well, we'll do our best to publish those comments that we receive that the sender would like us to publish.
Yeah.
And given that it does take some effort, they might not come like immediately, right? It might be that they're batched once a month or something like that. I think that's a reasonable.
Okay. Any other housekeeping or comments before I'd like to leave minutes for public comment? I can stay a couple minutes.
Just really quick, Tony, on your comment, if our preference is to publish, should we have it be, rather than have it be opt-in, should we have it be opt-out? Like, if you don't want it published, please tell us that. Otherwise, the plan is to publish.
Because we do get.
Yeah, they may not know what they don't know. They may assume that it's not going to get published and share a bunch of very personal information.
Nice.
And just Steve's point, you know, like if there was an opt out, then we might have to go and get permission, and if, you know, and they could tell us after the fact too. I mean, you know, hey, I made this comment, I intended it to be public. I think we're trying to be transparent and just make sure that we don't breach somebody's trust.
For either of those options, I would support either. I support the process. But we should make sure we have a legally valid statement on our website that states what will happen with this and whose responsibility it is. Needs to be clear, it needs to be legal.
And you think you can?
Yeah, I'll work with James on that.
All right. Well, let's open it up to public comments. You know, at all meetings, we take public comments. We're happy to hear from you. I'm gonna just skip a whole bunch of protocol. Anyone wish to make public comments?
Hello, my name is Vinny DeMarco. I'm the president of the Maryland Healthcare for All Coalition. We're thrilled to be here with my colleague Catherine Kirk-Robbins, CEO of the meeting. We're thrilled you all are doing what you're doing. I'm just here to say real quick, upper payment limits work. And you talked about Enbrel in Colorado that's going to save Coloradans millions of dollars starting January 1, 2027. I'm proud to say that the Maryland Prescription Drug Affordability Board on April 13th set an upper payment limit for state and local governments for Jardiance. And that's going to save state and local governments starting January 1, 2017, $320,000 a year, just state and local governments. And our expert concluded that when they can go statewide, like you can do at January 1, 2028, that's going to be up to $16 million saved for Maryland consumers and patients. We believe that on Monday, May 18th, our board is going to set an upper payment limit for Ozempic. And that's going to save state and local governments $5.8 million a year. And when they can go to everybody on January 2028, it's going to save up to $164 million a year. That's only 2 drugs and millions and hundreds of millions of dollars of savings. Upper payment limits works. I know we heard somebody say earlier, what if they don't sell the drug in the state? They're not going to not sell the drug. What your board member said, they're going to make a lot of money. And in addition, what we've responded to that is that in Maryland, like in Minnesota, if you advertise a drug and don't sell it, that violates consumer protection law. They advertise all these drugs. And just a real quick kind of suggestion, I would urge you to, what you're doing is what Maryland board did, but to take advantage of what Colorado and Maryland have done and put on a fast track the drugs that those states have set an upper payment limit, because they have done all the cost review and everything you're doing. I know you have to go through a process, but I would urge you to put those on a fast track and look carefully at also what the Virginia legislature did to say that anything that has a maximum fair price should have an automatic upper payment limit. We're going to pursue that legislation in Maryland next year. And I think we can make 2027 the year of UPLs all across the state. Thank you very much.
Anyone else? Anyone online wish to offer public comments? Your hand. I'll see none. I guess we need to make a motion to adjourn.
So
Second. Take the roll.
Craig Acom,
Aye.
Matt Anderson.
Aye.
Erica Barnes.
Aye.
Tony Laurie.
Aye.
Nick Day.
Aye.
Stephen Chandlemire.
Aye.
Matt Tobin. Aye. We have 7 ayes and no nays. The motion passed.
All right, we are adjourned and it's not published yet, but we will be meeting next on July 2nd. Thank you all for time and attention.
Vernon, I did get my